Good morning, everybody. I can see people are joining, so you're very welcome. I hope everybody had a good night. Everybody's refreshed, and I know for some of you it's already the afternoon. Here in London, it's 9 o'clock in the morning at the moment. So welcome, everyone. This is day 2 of our infection prevention and controlling antimicrobial resistance transmission workshop. And the workshop, as you know, is brought to you. It's a joint collaboration between PANDORA IDNet, CANTAM and Alert, and facilitated through the Global Health Network. We had some very good feedback already from yesterday. We had 3 excellent presentations. Today, a slightly different structure. So we've got 3 sessions today with 4 speakers. So we're going to have the first session, then a short break, a 15-minute break, and then the second 2 sessions will run one after the other, and then we'll have a final question and answer and a wrap up at the end of the day. So you can see the timetable there. I think everybody knows the drill, but just to go through it, remember that we've disabled, or I haven't, TGHN have disabled your camera and your video and your mic, because this is a webinar, so that we can run smoothly. But we will be able to, if you're asking a question, we will be able to put you on so that you can ask that and we can see you and hear you. So we're asking you keep your videos off, your microphones muted. If you want to post a question, you can see it maybe at the bottom or the top of your screen. There's a little Q&A icon, which has got 2 little speech bubbles. So you just post your question in there. You'll have seen that yesterday, sometimes some of the questions are answered in the box, and sometimes we are actually choosing to talk about them in the Q&A session. So we're doing both. Just a reminder as well, if you want to use the chat function to talk to each other, that's the function with the 1 little speech bubble. And I can see a few people are saying hello already this morning. So hi, everyone. Just a reminder as well, to get a certificate of attendance, and I know everybody would like one of those, you do need to attend at least 80% of the workshop each day, and we will have an evaluation that you need to complete. We'll be sharing that in the chat box, and then Heather will be sending that out via email. We'll also talk a bit later on at the end about 1 or 2 other things we're going to include in the email. So I think I can see we've got about 50 people joined so far. So I think we're going to start because we've got a packed programme today. So I'm going to hand over to our first chair today, is Dr. Isabella Honeybourne. Isabella is based at University College London, where we're speaking from this morning. And she is the project manager for the PANDORA ID network. And before that, Isabel's been a research scientist and laboratory manager, both in the UK and in South Africa. And she's mainly been working on studies with HIV and TB. So Isabella, would you like to introduce the first speaker, please? Thank you.
Thanks, Mags, and thanks for that introduction. So our first session this morning is on decontamination and waste management. So I'm very pleased to introduce Michael Opayo. I hope I'm saying your name correctly, Michael. He was born in Kenya and he still lives and works there now. His background is as a medical laboratory technologist, and he's currently studying for an MSc in occupational health and safety. For which he has a special interest in ergonomics in the workplace. He has 17 years of experience, and he first started working in hospital environment. Then he became a lab manager and then became part of the medical research field. He's a lab health and safety officer for CEMRI, Wellcome Trust research program in Kilifi, and he's been doing that since 2015, excuse me, though he started the health safety work in 2011, so he has lots of experience. Part of his role is in training, and he conducts program-wide training on the health and safety covering various topics, among them infection prevention and control, risk assessments, and waste and spill management. So I'm very pleased to hand over to Michael. Thank you, Michael.
Thank you very much for that elaborate introduction, and welcome everybody for today's presentation, which I have to thank my colleagues yesterday, Dr. Chiara and Reddy, as well as Lizzie, for laying a very good foundation for today's presentation.
Michael, before you
not
presentation,
wasting much time.
Michael,
yes.
Please could you go through and change?
Are you able to see it
very quickly?
Yeah.
So the display setting button at the top that we went through just before.
Okay.
So the button that says display settings.
I can't see the button now. The button is gone. I can't see it. Okay, I've seen it. Can you see it now?
I think it's just loading.
Is it there?
Yeah, and then the one that says swap presenter view and slideshow. It looks like it's just loading.
I think it's loading.
Great.
How about that? Are you able to see now?
Oh no, that hasn't actually worked.
I'm sorry.
That's okay. Could you maybe escape the presentation mode and try again? Exit presentation mode.
Let me see, yes.
And if you try and share again, it might pick up. And then if you try the display settings again, and then the swap presenter view. Yeah, that's great. Thank you so much, Michael.
You're welcome. Sorry for that. So we are going to talk about disinfection, decontamination process, and waste management with regard to hospital hygiene. And the objectives that we have today at the end of this presentation, you should be able to understand the general terms and principles of decontamination and waste with regard to hospital hygiene. You'll also be able to learn different ways of decontamination, learn about hospital waste management, especially with regard to COVID-19. We also be able to learn the management of blood and bodily fluids spills, and also be able to understand environmental cleaning, as well as understand how to handle patients or move between patients in the hospital or in their wards. Also, we are going to be able to learn proper management of sharps and understand the risks associated with specimens. And finally, we'll be able to understand better hospital linen management. So to start us off, decontamination is the means by which contaminants are removed from or rendered free from an object, substance, surface, or solution. The aim of decontamination is to prevent the spread of infectious diseases or toxic substances that could endanger life. It is a common procedure that is usually done in patient care facilities, in food preparation processes, environmental and forensic science. So for us to be able to manage or to achieve decontamination, we depend on the disinfectants, which work by the means of destroying the cell wall of microorganisms or interfering with their metabolism, as seen in this figure. So first of all, if I can show you by pointer. So they diffuse through the cell wall, and then once they get into the cytoplasm, the bacterial cell wall will be destroyed. There are various types of contaminants that can be used to achieve this hygiene, and they range from air disinfectants like glycol. You can also use alcohols, like the one mostly used is ethanol. We also have aldehyde that can be used, and that's where we have chlorine. We have peroxy and peroxo acid that can be used, phenolics, quaternary ammonium compounds, inorganic compounds, and also non-chemical units. Their use depend on the environment that needs to be decontaminated. Something very important before you start using the disinfectants or for the decontamination process is to remember the use of manufacturer's recommendations when preparing them. Because if you don't do that, then you will get the wrong concentration and their activity might not be working properly. Then you also need to think about the target agents that you want to disinfect, so that you can select the best disinfectant for use. Once you are prepared, remember, for their action to be perfect, you need to give them contact time. For every agent, they may have different types of contact time. So you need to give them time to act on the surface to disinfect or remove the contaminants which are found there. As well as you need to consider the toxicity and the ease of use and their stability. For example, you don't want to use a disinfectant which was prepared last year to be used today. So they need to be used fresh and to make sure that their stability is maintained. Going into the waste, as a term, waste actually is referred to as an unwanted or unusable material. This is after being used primarily in the procedures that we use. Then after that, maybe they are now unusable or they are unwanted. They could be worthless substances or the ones that have become defective. So that would be called as waste. And they include things like municipal waste, solid, which are grouped as solid. We are going to see the categories of waste in this presentation ahead. We also have hazardous waste. We have wastewater, such as the sewage, and also we have for certain places where they use radioactive materials, then you will have those as waste, as well as surface runoff waste. So there are generally three categories of waste in the hospital or medical health care facility. We have a medical waste, which is a type of waste generated at healthcare facilities such as hospitals, physicians' offices, dental practices, blood banks, and veterinary hospital or clinics, as well as medical research facilities. Then we have biomedical waste, which is any waste generated during the diagnosis, treatment, or immunization of human beings or animals in research activities pertaining thereto, or in the production of or testing of biological specimens. It includes used disposable blood culture bottles or tubes, used disposable culture plates and media, broken glass, and needles, generally called sharps. They also include used pipette tips and used contaminated and non-contaminated materials, such as gloves, paper towels, gauze, cotton wool, and all such kind of things. Then we have solid waste. This is defined as all non-hazardous solid or semi-solid materials which result from residential, institutional, commercial, office, industrial, construction, or demolition activities that are discarded as garbage, refuse, or other waste that does not include materials that is intended or collected for the purpose of recycling. It is therefore notable that what is now referred popularly as COVID waste falls under medical waste in healthcare facilities or biomedical waste in medical research facilities. So in the hospital environment, classification of the waste is supposed to be done as the first step in the management of the COVID waste. So all the waste that should be discarded are supposed to be classified as at the point of origin, so that we don't do the classification at the place where we want to discard the waste. We start with the place where you originate those waste and you classify them before they can be discarded. With regard to COVID-19 waste, they're supposed to be in separate bags or bins, which are directed to have clear markings these markings are supposed to be safety markings for the dedicated bins. So at the time the waste of classification, the bags must be disinfected and sealed properly before they are being taken there. Generally, for your information, biomedical waste usually contains 85% of general non-infectious waste, and only 10% are hazardous. The rest are either chemical or 5%. And chemical here, we are talking about even the medicines that are used or things that come from the lab procedures. So this figure here shows us the typical way of handling COVID-19 waste, whereby they originate from the ward. You can see that kind of busy ward of COVID-19 handling. Then they are classified into various bins. Then they are nicely disinfected and then tied up, ready for transportation here for collection. And they're usually taken to a particular or special place whereby they're going to be waiting there temporarily before they're transported for incineration at the end. This is this figure implies to places whereby you don't have the incineration or the destruction process or machinery in place. And this other figure also is just another flow of how the COVID-19 waste should be managed very well. And it is similar to the other one, but there is a note below here which says that incineration, even though it is the best way to dispose waste, if you have the sterilization process well in the hospital, then without the incineration, you can still be able to manage COVID-19 waste. So you can only plan to transport them to the place of incineration later on for final destruction. But at the very end of handling waste, you have to remember, because of COVID-19 scare in the world, you have to remember to wash your hands very well to prevent yourself from getting any residual viruses into your system. And this table here also shows us the kind of the different types of technologies that we can use for waste management or waste destruction, and they range from incineration to the use of pyrolysis, microwave, chemical, and vaporized hydrogen peroxide. So the table can show you the strengths and weaknesses of each one of them. For example, if you use incineration, it is it's very simple to handle or to operate. And the problem with that, its weakness is it requires a lot of energy to be able to perform its work. But the best thing with this incineration is that it reduces the volume, the volume of the waste up to 90%. These other ones may not be able to reduce that, but they're still effective. The problem also that is seen with the incineration is that it releases carbon into the environment, and this might not go very well with the environmental conservation, unless that incinerator is usually checked properly for its efficiency in burning. So you can use this table to see which one you can use better, and depending on the kind of outcome you want to have. Then I'm going to go specifically to various specific ways of handling certain things in the hospital, starting with the blood and body fluid spills. And these are just pictures of the things that you have seen in the hospital. This blood and this is the vomit, and you need to handle them carefully to avoid being infected with any organisms which may have come from the patient. So the first thing you need to do is that first of all, blood and bodily fluids are grouped as biological materials, and they include spills of free-flowing blood components, materials soaked with blood or other body fluids, waste that has been in contact with blood, feces, urine, patients with highly communicable diseases. So remember that when in a spill, it means they are not contained, and that should be the priority to prevent further spread. So In other words, whenever there is a spill, remember that if they spread, then you are endangering the many lives in the hospital. So as much as possible, we must be able to prevent their spread in the area where they have been spilled. And spills of this nature need to be handled very carefully as they bear risk of infection, and therefore you have to take utmost care when you're handling them. What happens is that the nature of the risk, or the nature or risk of the biological material, the volume of infectious agent involved in the spill or release, the agent, its transmission potential, and the normal route of entry for infection, and the location of the spill greatly affect the steps necessary to respond to the spill. So in any case, the use of appropriate biological spill kit is highly encouraged when handling both the blood and bodily fluids. So to be able to do this very well, what you need to do is to change your gowns and clothes that are visibly soiled so that you don't contaminate yourself. And the next step that you need to do is to warn people around you so that they are aware that there is a spill. In case they want to pass through that place, then they will not be able to be contaminated or to be affected. Then you need to put on the proper PPE for handling the waste, the spill. Remember, spills, the way you are going to handle them depends on what has been spilled. If you have spilled something which has aerobic organism, such as SARS-CoV-2 virus, or something like TB, then you need to have a respirator to protect yourself from getting that. Otherwise, you will be affected by the spill itself. So it is important that you cover the contaminated area with absorbent paper. Remember, we are talking about containing the spill. So remember to cover that area with absorbent material, which is soaked with disinfectant to stop its spread. And then the way to apply the disinfectant is from the outside, going into the inside of the spill. And you need to remember not to make aerosols coming from there. Otherwise, they will also rise up and then you can also get infected. These disinfectants, they need time, contact time that you have talked about. So you let it take effect so that you can be able to work on the contaminating material. After that, you sponge the area, dispose all the wastes and anything that has been contaminated into the appropriate container. Usually it is in the infectious waste bin. And be very careful if there was anything that is involved as sharp, then they have to be picked carefully using tweezers and placed in their special container, not in another, in the same container with this other contaminated material. We are going to talk about best ways of handling sharps ahead. Then remember, the spill may have happened inside the ward or somewhere close to the patients. Then you need to disinfect the items like the mattress and other materials on the patient bed, surface of the furniture, equipment, which may have also been contaminated. After that, then you remove your PPE and then you dispose all the contaminated material or the things that may have come into contact into the normal bin, and autoclave those that can be autoclaved before they can be incinerated. For institutions like healthcare facilities, there are certain requirements that they have to have in place to be able to handle spills of this kind of nature. Number one, they need to be able to train their workers on spill management and general precautions against those spills. This is very important because it is true that people can get infected from mishandling of these spills or this kind of releases. The other thing that they need to do is to have systems which immediately are available for reporting and managing exposures to the blood and body fluids. This is going to be able to help people who are in charge of their health and safety, or even to report in case of injury. Then this kind of reporting can help ahead when there is need for other actions. The institution should be able also to vaccinate staff who are at risk against preventable infections, such as hepatitis. You need to have people are vaccinated against hepatitis or yellow fever or other kind of diseases which we have vaccines against, especially if these people are going to handle this blood and bodily fluids. Then, because this is an emergency system, occurrence, there should be an emergency system readily available to help staff who are handling these kind of substances in the hospital. So we are going to talk about now environmental cleaning, which our target is the frequently touched surfaces in the hospital or around the hospital area. So what we are going to do is that environmental cleaning usually starts with just normal cleaning with water, with soap and water, or using neutral detergent. And that can only remove, it can remove, if you combine disinfectant there, it can remove pathogens or significantly reduce their load. But still, it's just as an essential step in disinfection. So when combined with some form of mechanical action like brushing or scrubbing, cleaning can also remove or reduce dirt, debris, and other organic matter such as blood, secretions, excretions, but still does not kill microorganisms. So it is therefore important that a chemical disinfectant such as chlorine or alcohol should be applied after cleaning to kill the remaining microorganisms. So these are the examples of the common chemical disinfectants used in the environmental infection. As you can see, we have the commercial bleach, this in the first picture. Then we have ethanol, and then we have hydrogen peroxide. How they are being prepared, we are going to see ahead. What you need to do is to consider which environment is involved before you use the disinfectants. So it will help you to use the most suitable for that kind of environment and the kind of methods that you're going to use and the tools that you're going to need for use for cleaning and disinfection. It is mandatory that you must use PPE while cleaning because there are also other dangers from the disinfectants themselves, apart from the infection that you can get. Always remember to follow the manufacturer's instructions in preparation because the different people prepare or manufacture these things in different ways and their instructions could be different. WHO has recommended the use of 70 to 90% alcohol for cleaning the environment, as well as a solution of sodium hypochlorite, a solution of bleach which is containing sodium hypochlorite at 1,000 parts per million for the general environmental disinfection. But when it involves spillages that we have talked about ahead, then you need to prepare 5,000 per million of the bleach solution to be able to achieve the disinfection process. You can also use at least 0.5% hydrogen peroxide concentration for environmental cleaning. So the instruction would be from the manufacturer's instructions, which are always on the label. If you are the person performing this procedure, you should ensure that you have adequate ventilation. Otherwise, some of side effects of this can be affecting you, as well as the microorganisms that you're going to disinfect against. So remember that the recommendation that has been given by WHO to use 0.1% or 1,000 parts per million for bleach does not only kill viruses, but also kill other pathogens that may be found in the environment. So it is a very safe one to use when you want to clean up or to achieve hygiene in the hospital. And as we have said that if there is a spill more than 10 mil, that is a lot of spill, then you need to use a concentration of 0.5% of the bleach as a recommendation. So the environmental cleaning techniques and principles should be as followed as possible. Now, this will depend on the kind of area that you're cleaning. For example, if you want to clean floor, you might need to use scrubs and mops. If you want to disinfect things like rails, then you need to spray. And as ventilation is key when you are doing this, as we have talked about, and then never mix the two. If you want to, let's say like you want to keep something like synergistic effect that is usually done for drugs, it is not recommended that you use mix these disinfectants together, because they are chemicals. They can react together and they can produce bad things that can actually harm your life. Now, you might be asking this question: how long or how frequent can we clean or disinfect certain places? So WHO again has given us a guideline here. For example, in the inpatient rooms which are occupied, they have patients inside there. It is required that at least twice a day, if it is not very badly contaminated, but even 3 times is recommended. And again, you have to additional guidance here, which you need to focus on highly touched surfaces, which I'm going to give you a few examples. So you can use this table as well to see, like for example, triage area, like we talked about yesterday. How many times do you want to clean it? You will see on this table. Outpatient rooms and hallways. And there is a footnote here that environmental surfaces should be cleaned and disinfected whenever visibly soiled, if contaminated. That is, you don't have to stick to this frequency if there is already something you're seeing as a or as a pathogen or soiling of certain surface. So you need to remember that. And then in the hallways, if it is frequently used, it can be cleaned more than once. So you can even do twice per day. Then we talked about the recommended concentration of bleach that can be used for disinfection of the environment. Here I'm giving you a guide on how to prepare 1 liter of the 0.1% bleach. So depending on the concentration, which is on the first column here, as we talked about, various manufacturers may have different types of concentrations of sodium hypochlorite in the bleach. So depending on the one that you see from the manufacturer, then you use these volumes to mix water to achieve the 0.1% or the 1,000 parts per million of sodium hypochlorite in the solution for disinfection. As a rule, during the pandemic, usually, regular cleaning schedules have to be followed, and disinfections are supposed to be done on frequently touched surfaces. These areas which I'm talking about are things like the tables, doorknobs, light switches, countertops, handles, desks, phones, and sometimes when people come to visit, or the patient himself or themselves, they'll be touching the rails of the bed. So those are frequently touched surfaces that you'll be targeting when during the cleaning. And cleaning of general surfaces and fittings immediately when visibly soiled or after spills. And after spills, this is stressed so that you don't have to wait for the schedules only, but be on the lookout when you see something in the vicinity. Then we want to see how to handle patients in the ward, and also when moving in between them. These pictures can tell you the current pictures in the world, what is going on. Sometimes you might be working in groups as these ones, maybe doing operation or trying to fix a vein. And here, trying to check on the patient, how they are doing, or maybe they need some service. Or maybe they are coughing or sneezing, you need to keep distance. And during certain operations, remember, you have to still use your PPE to prevent yourself from getting infected. In other words, your safety must come first before you handle a patient or before you move in between the patients. So at all times, handling patients, especially those who are having COVID-19, you need to wear PPE. And this is appropriate PPE, as we have seen in the pictures that have passed. Now, handling also involves how to communicate with those patients, and you need to be ethical when you're handling the patients. They might be having conditions that are not because of their own making, or is because of by bad luck. Still use ethical means to communicate to them, to give them instructions, to ask for a sample from them, specimen, or move them from one place to another, things like that. Then when you're moving in between those patients, Remember, they could be, that's the time you can also get infected. And the environment around there also could be dangerous for your health. Therefore, you need to use your PPE at all times. And then if there is any suspicion that one of them has coughed or maybe sneezed, or even if you don't know, please follow the disinfection procedure before, and then you change those PPEs appropriately before you can come back. So this is a simple guide on how to handle patients, which has been drawn for us to see. The first one is you have to have a safe people handling assessment. So you assess in the patient, in the wards, and how do you handle people carefully or safely. So you need to conduct that one before you start the handling, or you conduct this training for people who are going to handle the patients, so that when they're going to do that, they are going to handle them safely. So as again, number two there, you need to ensure that training is done for people who are going to do the handling of the patients in the hospital. And then the movement of patients, they need to use hoists, or they need to use other means to prevent certain problems coming to them, which I'm going to talk about ahead. It is important that you avoid manual handling. Instead, assist people to move, to walk, assist the patients to move from one place to another. If possible, use other means of transporting them or moving them safely in between, also transferring them to another place. You have to remove or reduce risks. So this one we have talked about a lot ahead in the other slides. So this will involve some risk assessment. Therefore, you do depending on the kind of environment in which you are working on. So you have to do this and to be able to be safe from or by handling the patients. You need to complete a pre-transfer assessment before you transfer a patient. This will involve whether this patient is still infected or this patient is having other kind of problems that can endanger your life. So you need to do that kind of assessment before you start. Then you use the principles when undertaking any transfer of principles of safety when you are going to take a transfer of this patient. And then you complete the completion of the task. You need to reflect what you have done to see what you can improve on and things like that. If you do this, we will be able to handle patients carefully and safely in the ward. Going to the SHAPS management, which I talked about in the beginning, SHAPS are generated in hospital, are part of infectious substances. Remember when we were talking about the categories of waste, SHAPS was one of those that was put under medical waste or biomedical waste. They have their own special way of handling. And sometimes people have not handled them properly and they have ended up having injuries. So what we need to do is that you must follow the waste segregation to be able to handle SHAPS properly. And extra care must be taken to avoid injuries from SHAPS. I think this is trained. People get this training before they work in the hospital. How you don't have to recap needles. You have to use them in a certain way that you cannot injure yourself, or make sure the patient is well seated before you can use them easily, safely, to avoid injuries. They are not supposed to be mixed with the other wastes at all, because they have their own problems, and that's why they have a special bin which you are seeing here, which is resistant to prick or puncture. They have to be well labeled. You cannot put them in just any bin which is not labeled, and they are usually destined for incineration because some of them are metal, some of them are glass. So the best way to remove them or to destroy them is by incineration. Before you take this bin to incineration or for disposal, it has to be well disinfected, because somebody else probably is going to carry it after it has been sealed, and therefore it has to be safe for transportation. So these are some of the pictures that I have prepared here for you to see poor sharps management. For example, this is cluttered on the floor of the hospital. The needles have been used and just left there. You can see this is a place they've just been collected together here and not in a special bin. This is very bad. Anything that is airborne can also come from here, and you can get sick from that. And somebody here is trying to put the sharps in a biohazard bin, which is supposed to be not used for general hazardous waste, not a sharps bin. It's not the special sharps bin that's supposed to be used. And again, this is how it might look there inside the bag, inside there, the red bag there. So these are not allowed to be used like that. And here they use the correct bin, but it is full, so full that the needles are sticking out and can cause injury for needle spray. So the best way is to have them in special bins, and they must not be very full before they are being disposed. Now, going to the specimens, there are many risks. There are many risks that are associated with specimens. And number one, we have to remember that specimens are majorly biological hazards, and they bear biological risks in that case. So there is a risk of infection that you can get from taking a specimen. So these infections can vary from very many different types of organisms: HIV, SARS, CoV-2, which is now very much in the world. You can also get salmonella or parasites from a specimen. There is also a risk of injuries which can come from needle stick, cuts, or etc. There is also the storage risk or concerns. Now, this, you need to remember that you need to prepare a storage space for these samples. If you do not have a storage space or they are not well stored, then you have the risk of loss or the risk of their deterioration, which you have to contend with. Then we have the risk which are associated with transportation. For example, if they are not well packaged, then you also risk infecting couriers who are going to transport this sample, these specimens, to wherever they are going to be destined for being analyzed. If the transportation system is not nice, then you also have the risk of delays and also the risk of breaking laws if you do not follow the regulations that are supposed to be followed when packing a certain kind of sample. The most important one which I want to mention here is the IATA, WHO IATA regulations for transportation of samples. So you have to be able to comply with those to avoid any kind of regulation breaking of laws. Then we have the legal risks. This may range from different areas. For example, before you have to take a sample, you need someone to consent. If they don't consent, there is a problem. They can sue you later on. So you have that risk of legal contention. So again, the use of a specimen needs a prior plan and communication to the patient or to the people who are going to give you this specimen, so that you are able to do away with those kind of legal issues. Then there's a final risk here of economic issues. This depends on the way collection of samples are done. They are depending on the patient, depending on the environment, depending on the tools. Then you might also suffer some economic risks there. And during analysis, especially those who are going to analyze them in the laboratories, there is also the use of equipment and the storage of these specimens. All those can contribute to economic risks, which are various, and we can talk about them in details much more later. To be able to control these risks, you need to do risk assessment. So the risk assessment will be able to help you determine the nature of the risk of the specimen. For example, which kind of infection can you get from there? It will also help you to determine the likelihood of the occurrence of that risk. How often? Because it depends on your place where you're working. Maybe people are not well trained, so the likelihood of infection is high. Maybe you are in a good place, the likelihood is low. So risk assessment will be able to tell you so that you target the control measures properly. And also, it will also help you to to determine the consequence of exposure. For example, if you get exposed to corona, then the consequence is going for isolation. It may be bringing some other problems like psychosocial hazards. So remember all kind of these kind of things. If you can do them through risk assessment, you'll be able to make proper decisions when you're handling specimens, and then to avoid the risk associated with them. So going into the linen management in the hospital, these are the types of various types of linen that are used in the hospital, and they range from PPE, as you can see, scrubs there, and also beddings, which you can see over there, and also the procedure linens, which are used in the hospital. Usually, all linen must be treated with disinfection before washing. And if you see visibly that they are contaminated and they cannot be used again, then they need to be autoclaved before disposal. We are only targeting to protect people who are going to handle them. So autoclaving is very key before disposal. This is an idea that patients, COVID-19 patients, their linen should be handled separately from the usual linen before usual laundry. Putting them separate will help you to disinfect them properly, because the virus can also stay in their linen long enough to be able to be transmitted to another person. So if we handle them separately and then disinfect them properly, then they can now go through the usual laundry process with the other linen in the hospital. And here is the figure which demonstrates the concept of hospital linen hygiene, which we all need to achieve in various healthcare facilities. As you can see, there are two sides of this of handling hospital hygiene. The two sides ensures that there is safety, there is no contamination in the right side of in the clean laundry room. So when the laundry comes from the hospital or wherever they're coming from the offices or from the staff themselves, they are delivered through a barrier, which these people who are doing the laundry are not supposed to be in contact with those kind of contaminated material. So every facility should make sure that there is this barrier of handling of linen in the hospital, whereby you separate the people who are doing the laundry, and the collection and the transportation is done safely. When they are all done and processed for the reuse, then the transportation which was used for them needs to be disinfected. You don't need to use the same kind of material, for example, trolley or the vehicle that you use before it is disinfected for the clean laundry. So if we use this kind of concept for handling linen in the hospital, I think there will be no transfer of infections from the linen to other places. No one should get infection from linen which has been used. Finally, I have prepared for you a number of references which I have used for making this presentation, and I'm sure it is going to be available for you for perusing. And you can read from all this to see further details on what we have talked about, and I think we'll be able to achieve the goals that we set in the beginning as our objectives. Thank you, and stay safe.
Thank you very much, Michael, for that comprehensive overview there. So we're now going to move to question and answer session, and we're going to invite a couple more people to the panel. So I'd like to invite Mulemba Samutela and Ken Awondo, who will help answer your questions. So if you've got questions for the panel, please can you type them in the question and answer box now so we can get some discussion going. There have been a few questions, so we'll kick off with those. Guy Arno seems to be asking some very good questions this morning, but it'd be great to get some from other people too. So we'll just start off with Guy's questions. First question is, when considering bleach, what's recommended? So tablet bleach, so hypochlorite tablets, or liquid? And also for TB activities, should we use both ethanol, 70% ethanol and bleach? So I'll hand that over to Michael to begin with, and then we'll ask the other panelists if they add anything.
So to answer that, when you are using, it depends actually. There are people who prefer using the powder, the granules, and there are people who prefer using the solution. For safety purposes, granules, if you have them, then you need to have means of handling the granules safely during preparation. For example, the use of fume hood. So if you have it, then you prepare the granules in the fume hood, because if you breathe the granules dust, it might be injurious to your health. The problem with the solution also, they come in various concentrations, as we have seen. So maybe if you get one today at 5%, another one will be at 3% the following day. So if you have made your SOP or standard operating procedure for preparation, then you might be able to dynamically change that SOP every time. So if you have fume available, then you need to use the granules and prepare the correct concentration so that your SOP remains the same. With regard to TB, there are things called Has granules, which you can use for disinfection, as well as chlorine can still work for their disinfection. I hope I have answered that question. Thank you.
Michael. What about Ken? Ken, have you got anything to add to what Michael said there?
I think Michael has answered it well, and I don't need to have anything. I probably might spoil it if I add anything. So thank you, Michael.
Okay. I think there was a question whether people should use both bleach and ethanol, or whether, I think that's the question, whether they need to use both, or whether one.
Okay, just to give a guideline there, bleach, if you use it, usually you need to give it time. If you're doing a procedure, for example, which you need to work very fast, alcohol is known to work very fast to kill the virus. So you can use alcohol on surfaces which you need them to dry as fast as possible. But when you use bleach, then you need to give them time for activity to kill the virus. Then you can be able to use. But you don't, mixing the two does not help, as we have talked in the presentation. If you use one, it's equivalent to the other one. So just whichever one you use and whichever surface you want to disinfect is the key. Thank you.
I guess for TB, you've got to think about what sample it's in as well, because sputum, for instance, is very proteinaceous, and that may deactivate alcohols. It's quite difficult for alcohol to penetrate, things like that.
Yes, yes, true.
Malemba, do you have anything to add to that discussion? Are you there?
Hello, yes, I'm here. I think they have done a good job in answering the question. We could move to the next question.
Okay, so in terms of Sharps container management, we are using mineral bottles instead of the recommended Sharps containers. Is this a good alternative in low resource settings? And also, he wants to know if autoclaving is the standard before incineration, I assume, for these containers. So Michael, I'll hand over to you first on that.
All right, so the use of mineral water bottle as a Sharps bin is not a safe practice. So I wouldn't recommend somebody to use that for disposal of Sharps. And only a few, I mean, if you check the opening of the bottle, it is quite small, and that might also interfere with what you're going to put inside there safely. I think there are many in resource constrained countries. There are many alternatives that can be used. There are several bins which are safer and cheaper, which we can use in case you can't get the correct Sharps bin. So that I would not encourage it to be used. The other question was about, can you remind me, please?
I think it was about whether that you need to autoclave before incinerating the Sharps containers. I guess mineral bottles or proper sharps container.
Oh yes. So autoclave is a standard way of disinfection. Since we are talking about decontamination and disinfection, it's a standard way to remove microorganisms before they are incinerated. Because especially if you're working in a microbiological environment, this is one of the requirements that all infectious material have to be autoclaved before they can be incinerated. And I think that is where we end at that point. It's a standard way before incineration when you are handling microorganisms.
Thank you, Michael. Ken and Malemba, do you have anything to add to that?
I think Guy is in, as he said that he's in a low resource environment settings. Even though it's not recommended, but sometimes you have to be innovative and sometimes you have to be creative. If you really don't have anything like a sharps container and you can find something that's alternative and which can work, that is fine. That is fine with me, but it's not recommended. But if you are in an environment or you are in a setting that probably lacks some of these things, then you have to be creative, which is good. And I think what Guy did is fine because he did not have a sharps container, but he brought in the mineral water, which actually used them for storing the sharps and then taking them direct to the incinerator.
So in that case, Ken, what they need to add, which is okay for innovation, they need to add a proper label so that people are warned, yes, before they can be used. Yeah.
Okay.
Maybe just to add, I liked what Michael said, and the size of the opening of the mineral bottle water being too small. So perhaps an alternative could be to use the 2.5 liters containers for most of the lab reagents, like the ethanol, slightly bigger and a bit more tough in terms of the material of the container. Otherwise, as Ken has put it, we must always find an alternative when we have these resources.
Yes.
Thank you.
Okay, so let's move on. So a bad waste management system could be a potential risk for AMR development. If this is so, how could this be? So obviously, we talked a lot about AMR yesterday and just bringing that into waste management. So I'll go to Ken first this time, to be fair.
I was also wondering how, but you know, if you have a bad waste management, some of these waste have got microorganisms in them. And so if they find their way into the environment, that could be a source of AMR. They could start resisting the drugs. But we also have Dr. Srinivas with us here, probably will also be able to help us. But I feel that if there is a bad waste management and the bacteria or the contaminants get access to the environment, that would be a source of the antimicrobial resistance.
Thank you.
Thank you.
Malemba, do you have something to add to that?
Yes, thank you. Yes, so just to agree with what Ken has said, imagine where the waste is thrown near, say, an ordinary waste dump, and this is near a river system, or the bacteria gets into the sewer system. So if this waste is coming from a patient who had an infection with an MR resistant bag, rather to say, it means that this bacteria is likely to be introduced to other environments, including the sewer, as well as people in the community, saying in instances where people go to pick from the dump site. And unfortunately, sometimes people go even to pick from hospital waste. So it is a potential risk for MR development, in that if part of the waste has the bacteria already, which is resistant, it can then spread its genes to the other bacteria. So yesterday we we had one presentation where we saw part of the mechanisms of transfer is the gene transfer, say via plasmids and all. So yes, I think it is a potential risk for AMR development.
Thank you for that, Malemba. That's a really good
So
point.
I have something to quickly, something to tell about that. Yeah, one thing is that even if we autoclave, I don't know, just I'm bringing out the for the discussion. Even if we autoclave, whether we will get rid of the plasmid or something, because it will kill the bacteria, but the genetic material, whether it will be intact or it will be like degraded complete, is still questionable. Because if the DNA is present, still it can be transferable to the other bacteria if it is not disposed properly, even if it is autoclaved. I don't know, it's my personal opinion. I don't know in detail about how things will go on in the environment. Yeah.
Anybody want to respond to that?
Yeah, I think the question is important, but the how is very hard to tell.
Yeah, I agree with you. It's like very complicated. Unless and until we do something, then it's difficult to tell. Yeah.
Exactly. Yeah.
Okay, I think we'll move on. So is it possible to increase the concentration of disinfectant during an outbreak like COVID-19?
I will take that on. It is not important to increase the concentration. As we talked about the WHO recommendations, those recommendations work before and after, before, during, and even after the pandemic. They have been proved to kill the microorganisms at those concentrations. So just because we have a pandemic or a new virus, if the concentrations which have been recommended can work against it, then that's the best thing to go ahead with. Don't increase the concentrations. Thank you.
Thank you. Ken, do you have anything to add on that?
No.
No. Malemba?
Nothing. I don't have.
Okay. Let's move on then. So we have a question here from Claudine. Sorry, I haven't been saying people's names. Who's asking, apart from ethanol, what are the usual disinfectants used on virology benches? I don't know, it's quite a general question, but.
Yes, apart from ethanol, as I've mentioned over there, you can use hydrogen peroxide, which you have used. I have experience using hydrogen peroxide. It can be used directly on the surface, or it can be used in the environment, then closed environment or work area, using a fumigator, which is special for hydrogen peroxide. As well, you can use something which is called Vacon. It's a powder which you can also dilute to attain the concentration which can kill viruses. And we have used it safely to kill any viruses in the virology work. Thank you.
Thanks. Okay, so we have a good question here. Do you encounter any problems with personnel observing new and strict procedures? And I guess this is related to changes since COVID-19.
This is very, very important question. And yes, this is happening. It is very, very difficult for humans to change their usual behavior. That's why we continue to have the virus infection increasing in the whole world, because people wouldn't want to change. So when we put in new safety procedures, what my work majorly has been to constantly train and follow up on what people are doing. Once you train, then you follow up whether they are following or not. If they're not following, then you start to find out what is the reason why they are not following. Is there something which needs to be changed? So with the human beings, their behavior is very dynamic. Today they are behaving this way, tomorrow that way. So you need to find these reasons to make sure that safety procedures are continuously followed. There are always problems you are going to encounter when you introduce new changes, and you only need to get the solutions to continue and to be safe. Thank you.
Anyone have anything to add to that?
Yes, you know, yesterday Dr. Chiara talked about attitude when it comes to control, infection control. It's all about attitude. And as Michael is saying, it's not very easy changing people's attitude overnight in a week or in a month. That's the reason why every organization need to have somebody who is health and safety officer, so that this person should be looking at how people are handling the health and the safety in the organization. So human attitude is not very easy, and Dr. Chiara said that those are some of the reasons why we are having some infection problems in the hospital and also in our environment. Thank you.
Thank you. Okay, so this is a question, I think I'll direct this to Michael because it's kind of related to the presentation. Can you help me know why you need to separate COVID-19 laundry?
Good.
General laundry.
Thank you. Thank you for the question. I have just also written an answer. The most important reason here, because we know that the virus spreads in various ways, surfaces, and various situations. So we wouldn't want to endanger the life of somebody who's going to handle the linen if they're actually coming from known cases of COVID-19. So the best way, when they come from the COVID-19 isolation ward, they need to be separated before they are mixed together with the others which are going to be cleaned. So that separation helps in targeted disinfection before they are taken for laundry. That's the main reason for separation. There's no other main reason apart from that. I hope that is going to answer your question. Thank you.
Thanks, Michael. Okay, so we'll move on to what would be your advice on the use of bleach on a ward that cares for patients with respiratory infections? Who would like to take that first?
Usually the bleach is used for environmental, at the low concentration of 1,000 parts per million, it can be sprayed using special sprayers on the various places where the patient touches. For example, it talks about the rails of the bed, the floor around the patient, the toilets that the patients are going to, especially because they're sharing. Now, if this is going to affect someone's respiratory system, usually at the moment, actually, everyone is advised to put on masks. Because even if you use alcohol to spray, there are people who react to alcohol. So the best advice that I can give on the use of bleach is, first of all, the recommended concentration. And of course, you don't spray directly to the patient or somewhere around the patient whereby their respiratory system or respiratory infection is going to be affected. Yeah, that is the advice I could give, unless somebody else has something to add on that.
Ken, Malemba, do you have anything to add?
I do not have.
We'll take the next question then. I'll direct this to Malemba first, to be fair. How can one deal with waste segregation errors? I think it's a really good question. How can you correct errors if someone's obviously put waste in the wrong bins? Any ideas on that, guys? Malemba?
I think, let me ask Michael to start.
Okay.
Thanks.
All right, thank you, Malemba. So waste segregation, mistakes, that is the question. So if you, for example, find yourself to have put sharps in an infectious waste bin, which is just a lining, a polythene lining. So how do you deal with that? In most cases, the best advice we tell people is that please do not scavenge into the waste bin so that you can remove the waste into another place. The most safe way that you would have done, if it is not full, if, for example, I'm talking about waste sharps here. If you put it in a wrong bin and the bag is not full, the best would be for you to safely carry that bag into the shaft bin if it is just small amount. If it is large,
sorry, go ahead.
Carry on, Michael.
Then you need to use a special carrier.
Okay. Should we?
The waste bin, but usually the waste.
Sorry, I missed that. So we move on. So somebody's kindly put on an article link here for denaturing of a plasmid by autoclaving. This was a study that was done. So if you click on the link, you can get some information about times for autoclaving. Okay, so let's just take some other questions.
I just wanted to add about waste segregation. Some places they use color coding. So they have containers which are color coded. There is yellow, black, white, and they can say that infectious materials will go to the red color coded, and just papers without infection will just be put in a white color coded container. So again, that is something that the organization or the laboratory can put in their procedure, the laboratory procedure. You say that which color code is for what.
Thank you. Max, can I just ask you to take over as chair for 5 minutes? I just had an urgent call that I need to take. I'm really sorry about that. Max, are you there?
Hi there.
Thank you. Sorry, can you just...
Hello. No, that's okay. So where are we up to with the questions? I think, have we got any more? I think we've covered the questions.
There's
that were
Felix Asena's
Q&A. Okay.
question there.
Thank you, Heather. Ken, do you want to take this one? Michael?
I think that's what we have just talked about, is how
that's what I
deal with waste segregation errors.
Yeah.
Sorry.
That's all right.
Just to stress, Isabella, just to stress on that question.
Yeah.
It is important, as Ken says, that you need to do proper color coding for different types of wastes. This is a proactive measure, so that in the beginning nobody will take waste into the wrong bin. So if they are well color coded and people are trained on how to dispose the waste, then they will put them in the correct. That's the best way to deal with waste disposal errors. But if the waste disposal, even after the color coding still occurs, then another approach needs to be taken, as we have talked about before. Thank you.
Thank you, Michael. We had Techno had their hand up. Techno, come on. I can see you've put it. Do you want to post your question, Techno, or do you want to, or can we unmute Heather so that Techno can speak and ask the question?
I think Techno's dropped off the call now.
Ah, okay.
So there's, I don't know whether the question from Christiane or the question from Emmanuel's been answered in the Q&A.
I'm back now. I'm so sorry about that. Sorry, and thank you, Max, for standing in for me there.
Okay, I think we're just looking. There was somebody called Techno who had their hand up, but they seem to have dropped off, unfortunately. So I think we're looking at the questions from Christiane and Emmanuel in the Q&A, Isabel.
Okay. Sorry to interrupt. Techno's just come back on.
Ah.
So I'll just.
So over to Techno, hopefully.
Techno, are you there? No, we'll come back in a minute. Let's take these two questions that we've got in the Q&A. So Christiane has asked, concerning risk assessment in a microbiology lab, does this activity need to be updated? If yes, and how frequently? So how frequently, I guess, relating to disinfectants. Does this need to be updated in the risk assessment? Don't know, anyone want to take that?
Yes, I will do that. Thank you, Christian. Risk assessments need to be done and they need to be updated, usually called review. In most cases, the rules of risk assessment is to be done prior to the process, during the process, and after the process. That is the first cycle of risk assessment. So prior is to make sure that you are ready and you're going to be safe. During is to know if there are some other challenges in the process which need to be changed. And then the one which is done after the process has been completed is to see whether those challenges can be maintained, or the control measures can be maintained or need to be updated. So as a general rule, if everything is done in these first three instances, then usually they are reviewed every year. So you need to do them in the three instances, and then later on annual review will help. Or if something has changed in the process, something significant, for example, change of the process procedure, or a new equipment has come in, or a new employee has been put into the task, things like that will need review or update. Thank you.
Thank you, Michael. Does anybody else want to add anything to that? Seems to be pretty comprehensive.
Answered it well. Much better. Yeah.
I agree. Okay, so someone's sent me here, Kerry sent me Techno's question, so I'll just read it out. Please explain briefly about the chlorine mixture, both liquid and powdered chlorine, so I guess the tablets or granules, or compared to the concentrated hypochlorite, and more especially, how do strong and weak mixtures compare for disinfection purposes? Michael, do you want to take that?
Yes, chlorine mixture, which is the commercial product, there are many things which are inside there. There are things which are stabilizers for the chemical, and then there is the active ingredient, which is sodium hypochlorite, which is very key in the mixture. This is what we target during the dilution to achieve a certain concentration of activity against microorganisms. And then we also have the diluents. Most of the time, this is water. So that is what is inside the mixture. The most important thing that you need to remember is the amount or the concentration of sodium hypochlorite in the chlorine or in the bleach mixture, which is usually commercial. The powder or the granule is purely chlorine with a few impurities when you do the chemical analysis. So this one you directly put into a concentration which you can control inside the lab or inside the hospital, and then you dilute as recommended by the WHO to achieve the activity against microorganisms. I hope that answers your questions. Thank you.
Thank you, Michael. So we've just a couple of minutes over time now for this session. So we're just going to take one more question and then we're going to close this session. So this is from Emmanuel. In the past, we saw, for example, sharks being boiled and this wasn't safe. Then I hope it doesn't happen anymore. But in case it does, how safe is it? Okay. So I guess this wouldn't be best practice, but some request of how safe this is to do.
Yeah, this was a very old or ancient way of sterilization, or trying to achieve sterilization, because there is the principle of heat action against microorganisms. So it was being boiled to clear every kind of contaminant inside there. But when we brought in sterilizers, then that kind of activity should not continue anymore. Apart from sterilizers, now we can also use autoclave, which can also help us to make sure that we achieve that kind of sterilization. It's not a good practice, so I don't think it should be encouraged to continue. If it is still happening, I think we need to move up to a better way of being safe. Thank you.
Thank you, Michael. So we'll close the session now. I just want to say a massive thank you to Michael for a great presentation and for taking all the questions, and to our panelists, Ken and Malemba, for great input as well. So we'll go to coffee now. So I think we have a 15-minute coffee break, and we'll see you back at 10:30. I think that's right. So thank you, everybody.
So thank you very much to Michael for that very nice presentation that started off the session. And thanks very much to Isabel for chairing that session, and also to Malemba and Ken for fielding the questions in the Q&A. That was great. Thanks so much. A really good start to the day, and very nice slides as well, Michael, that will be great to have on the hub. So remember, everybody, you'll be able to access all of these presentations from the Pandora Knowledge Sharing Hub, and we'll put the link up later on. They'll probably be up in about 2 or 3 weeks, I guess. You'll be notified when they're up. So let's move straight on with the second session of the day. And I'd like to introduce our next chair, who is Kerry Ralston, who's a colleague of ours here at the Royal Free Hospital, which is one of the main infectious diseases hospitals in the UK. And Kerry's a clinical scientist here, and she's going to chair this next session, and she's going to introduce our next speaker. So over to Kerry. Thanks, Kerry.
Thanks, Mags, and welcome everyone to this next session on surveillance and monitoring of organisms. Our presenter for this session is Hannah El-Badawi. She is a postdoctoral research fellow at the Institute of Endemic Diseases at the University of Khartoum, who are a partner in Pandora. She has a strong research and scientific background with 9 years experience in research and laboratory settings. This includes working at the microbiology department in Sobe University Hospital and working with Doctors Without Borders MSF France. Her research interests include antimicrobial resistance, bacterial genomics, and infection prevention control. Thanks, Hannah, and over to you.
Thanks, Kerry, for this nice introduction. Hello, dear ladies and gentlemen. First and foremost, it's my pleasure to be part in this extraordinary workshop, and let me to share my slide. I grab this great chance to proudly salute and welcome all the participants and attendees as well. Thank you. Today we are going to speak about a very important topic, which is about surveillance, monitoring microorganisms. The outlines of this talk is background, laboratory surveillance, multi-drug resistant organism, key resistant profile, data collection, and screening. What is surveillance? Surveillance and monitoring are critical component of well-functioned public health system. A critical function of clinical surveillance is to provide early warning of disease outbreak that required rapid response at the regional, national, and international level. Method for surveillance. The type of surveillance method depend on the local factor, such as type and size of hospital and cases, and availability of resource. The type of method used by infection control team is laboratory-based in all world, and combination of lab and patient-based in all critical care area. To speak about the role of the laboratory in healthcare setting, actually, laboratory play a critical role in a diagnosis of disease and treatment monitoring. And indeed, laboratory surveillance allow detection of newly emergent pathogen, monitoring epidemic trends, and measuring the effectiveness of inventions. The laboratory and disease surveillance. Laboratory play a role before the outbreak in terms of early warning signals or outbreak detection. Or during the outbreak, laboratory can help in outbreak response and management. And in between the outbreaks, laboratory usually trend as trend monitoring, investigation, evaluation, and also monitoring progress toward control objectives. Lab monitoring trends. Example for the lab monitoring trends in outbreak, circulating strain of bacterial meningitis, example for the impact on treatment protocol or impact on immunization policy. And in antimicrobial resistance, laboratory in methicillin-resistant Staphylococcus aureus detect the trends of this pathogen, or vancomycin-resistant enterococci, and also in tuberculosis. Multi-drug resistant pathogen. Emergence of resistance to antimicrobial agent in pathogenic bacteria is growing, leading to severe infection and poorer patient outcome. As this problem continue to grow, harmonized definition and classification of these multi-drug resistant organism bacteria are needed so that epidemiological surveillance data can be reliable, collected, and compared across healthcare setting and countries. Multi-drug resistant pathogen, according to the ECDC and CDC, many pathogenic bacteria that are frequently found in healthcare setting, defined as MDR, XDR, and BDR strain. Example for this resistant pathogen like methicillin-resistant Staph aureus or vancomycin-resistant enterococci, carbapenem-resistant Pseudomonas aeruginosa, carbapenem-resistant Acinetobacter baumannii, penicillin-resistant Streptococcus pneumoniae, and ceftriaxone-resistant Neisseria gonorrhea. Transmission of these multi-drug resistant organism, once multi-drug resistant are introduced into a healthcare setting, transmission and the resistance of resistant strain is determined by the availability of vulnerable patient, selective pressure extended by the antimicrobial use, and increased potential of transmission from larger number of colonized or infected patients. The impact of implementation and adherence to prevention efforts. The global threat, health threat of antimicrobial resistance, the global spread of microbial resistance can be characterized as pandemic rather than epidemic. And the dynamic of human population, particularly in the past 25 years, have contributed significantly to the rapid spread of several multi-drug resistance. Example for this dynamic distribution, the 23F colon, which is responsible for penicillin resistant in Streptococcus pneumoniae. It was started in Europe, UK, France, and then spread all over the world within few years. And also another example, this presence of multi-drug resistant microorganism among Staph aureus infection. Yeah, it is increased up to 50% of Staph aureus pathogen. It was multi-drug resistant organism all over the world. It's vary from country to country, but in US and Canada, it's increase it up to more than 50% of Staph aureus infection. Another example, neonatal sepsis. About 70% of bacteria causing neonatal sepsis in developing world cannot be treated with an antibiotic recommendation by the WHO. That is why multi-drug resistant organism is a real problem, and surveillance among these resistant organisms is very important. Antimicrobial resistance has been increasing in both healthcare-associated infection and community-acquired infection worldwide. And surveillance to detect these multi-drug resistant organisms has been advocated for decade, and a healthcare organization surveillance program should monitor microbiology report for occurrence of resistant organisms of epidemiological importance to the facility. Surveillance culture and other microbiologic tests such as molecular rapid antigen detection test can also be done to monitor the incidence, prevalence, and transmission of multi-drug resistant organism. And once used primarily in outbreak investigation, the use of active surveillance tests has been recommended to identify colonization of patients and residents with multi-drug resistant organism in select population in non-outbreak situation have been widely debatable. Surveillance strategies. There are five strategies of surveillance, which is hospital-wide incidence, prevalence surveillance, target surveillance, unit-specific surveillance, outbreak. But in infection control team, usually use hospital-wide incidence surveillance as a strategy, which has the following advantages: provide data in all, identify clusters, establish baseline rates, recognize outbreak early, and identify risk factor. However, unit-specific surveillance should be considered in a special situation. Alert organism and condition surveillance. The microbiology department has response for informing all infection prevention and control team of alert organism and condition as identify that many potentially cause outbreak of infection and are identified as multi-drug resistant organism. Each organism will receive daily situation report important informing them of outbreak of infection. Example for alert organisms, there is many alert organisms, but organism which is associated with multi-drug resistant, like isolation of MRSA from bloodstream infection, or glycopeptide resistant enterococci, vancomycin resistant enterococci, group A beta hemolytic streptococci, penicillin resistant streptococcus pneumoniae, and multi-drug resistant coliform like E. coli, Klebsiella, Campylobacter baumannii, and isolation of ESBL and carbapenemase producing pathogen, in addition to Clostridium difficile infection. MRSA, the organism that was referred as MRSA or methicillin resistant is not the same as that announced MRSA, which is emergence in late 1970s, following the introduction of methicillin to deal with beta-lactamase producing Staph aureus. They are multi-drug resistant bacteria rather than just methicillin resistant, and MRSA can lead to serious infection, harder to treat than other pathogens. The clonal nature of nosocomial MRSA suggested that prevention of its spread with the infection control measure are at least as important as appropriate antibiotic therapy, which is very important. The second multi-drug resistant organism, VRE, Enterococcus faecalis and Enterococcus faecium are the common in the human gut. And interestingly, the most prevalent species of sensitive Enterococci is Enterococcus faecalis, but among vancomycin resistant strain, Enterococcus faecium is predominant. Vancomycin resistant tend to be colonial, spread around through a hospital population. Thus, infection control is important in their control. Another example, carbapenemase producing Enterobacteriaceae. Enterobacteriaceae are part of the normal range of bacteria found in the gut, and carbapenem producing Enterobacteriaceae are a type of that bacteria group which are resistant to carbapenem antibiotic. They carry a gene for carbapenemase enzyme that break down these antibiotics. Consequently, causing infection that are associated with high rate of death and severe illnesses. Treatment of this infection is increasingly difficult, and these organisms are often resistant to many, if not all, the available antibiotics in the health setting. Other example, carbapenem resistant Pseudomonas aeruginosa. Pseudomonas aeruginosa is inherently resistant to many antibiotics, but was susceptible to the cephalosporin, ceftazidime, and fluoroquinolones such as ciprofloxacin. Carbapenem resistance is rising particularly in hospital strain because Pseudomonas aeruginosa is particularly problem in patients with cystic fibrosis, as they are often succumb to lung infection caused by it. And patient-to-patient transmission is a major mode of carbapenem-resistant Pseudomonas aeruginosa acquisition. Other example, carbapenem-resistant Acinetobacter baumannii. Actually, Acinetobacter baumannii is a product of antibiotic era, because the rise of species of Acinetobacter baumannii occur only after extensive use of antibiotic, and it is already resistant to the second generation cephalosporin, and the introduction of the third generation cephalosporin was quickly followed by resistance because of the inherited chromosomal class C beta-lactamases in this organism. And the challenge by the fluoroquinolones trends and species that was originally ciprofloxacin sensitive completely, it's become completely resistant. So the drug of choice become the carbapenem. The mechanism of carbapenem resistance was different from all other bacteria, including Pseudomonas aeruginosa, the bacteria encoded as class D beta-lactamases, capable of hydrolyzing carbapenem, like OXA. OXA 23 was the first to be discovered in these bacteria. And there is about 5 other OXA beta-lactamases that are the most important one with Acinetobacter baumannii is OXA 58. And now there is many centers, Acinetobacter baumannii, it's sensitive to colistin only is found. Acinetobacter baumannii, it's a true XDR pathogen. Laboratory practice. Now we'll move to laboratory practice in surveillance. Number of the guidelines make a specific recommendation about the laboratory practice. They are recommending, first of all, a specific antimicrobial to be tested against the various organism group. Any organism group should be tested with suitable or with suitable antibiotic panel to detect the resistance. And the second, phenotypic detection by screening and confirmatory test or using chromogenic agar to confirm the antibiotic sensitivity testing, or genotypic confirmation, which is most accurate to detect the resistant gene or resistant mechanism associated with the resistant. And in addition to retrospective review of laboratory record when a new case is identified. In data collection, in surveillance, mainly where data to be collected include first, the patient information in terms of age, sex, unique identifier, unit or location, physician name, date of admission, date of onset, type of infection, and patient outcome, date of discharge, transfer, or this. In addition to information need to determine whether the case defined is met, like result of laboratory and diagnostic test is specified in case definition, and site and date culture, organism isolated, antibiotic susceptibility, clinical sign and symptoms specific for infection being monitored. The third group, risk factor for the infection being monitored. The host factors such as underlying condition, disease, surgical procedures, use of intravascular catheter, including date, duration, catheter type, and body site, and also mechanical ventilation and the duration for use. Now, surveillance and screening culture. Early detection of risk of high-risk patient and isolation reduce the opportunity of transmission between colonized or infected patients. And screening culture are primarily collected of the purpose of determining if a patient is harboring particular multi-resistant pathogen. Screening like screening for MRSA or screening for VRE or screening for multi-drug resistant gram-negative bacilli. Screening for MRSA, screening is normally done at a pre-admission clinic or GP surgery. Normally, the sample for screening will take a swab. It's taken from nose, throat, armpit, growing, or any damaged skin wound. Then culture in mannitol salt agar or chromogenic media, and antimicrobial sensitivity to detect what is necessarily resistant or not by using oxycillin or cefoxitin. Or we can use molecular detection for these resistance associated with MRSA, like MIC-A gene. For screening for gram-negative bacilli, most guidelines recommend screening previous post-case at the time of hospital readmission for the most multi-drug resistant gram-negative bacteria. Screening for ESBL or screening for carbapenem producing Enterobacteriaceae, Cyanotobacter baumannii, or Pseudomonas aeruginosa. The sample mainly is stool sample or rectal swab for ESBL and carbapenem producer. Microbiological tests for including phenotypic detection like AST, chromogenic agar, or direct synergy test. Or molecular detection of resistant gene associated with resistance. To speak about the recommendation of screening, which patient to be screened, this is ICMET recommendation. Use alert code to identify promptly a patient already known as colonized at hospital, ward admitted, and perform screening and pre-admitted contact precaution. Implement a program of active surveillance culture at hospital admission, followed by contact precaution. Screening culture should use stool sample or swab sample for from rectal or pre-rectal area, as well as sample from inguinal area and manipulated site, example catheter or broken skin or wound. The frequency of screening culture should be based on the local prevalence of microorganism, patient colonization risk, and the case mix of the unit. Considering performing active surveillance culture at the time of hospital admission for high-risk patient or for all patients in high-risk unit, such as cancer or ICU ward, according to local incidence or prevalence data. And admission, discharge, and weekly patient screening might also be considered to provide feedback to healthcare worker and to assist the effectiveness of interventions. Periodic or weekly active surveillance culture might be performed for patients remaining in the hospital at high risk for carriage of multi-drug resistant organism, gram-negative bacteria, because of a type like ICU, the patient with prolonged antibiotic therapy and underlying disease or long duration stay, presence of devices and surgery. All this, it's high risk for carrying multi-drug resistant gram-negative bacteria. Before transmission patient to another healthcare facility, acute or non-acute care, ensure communication of status. In conclusion, multi-drug resistant organisms are well recognized worldwide, and many countries have surveillance and control program to identify their occurrence and limit their spread. However, many nations don't have the surveillance or control program, and global surveillance systems are needed to rapidly detect multi-drug resistant organisms and institute measures to prevent further transmission. That we have to activate surveillance and infection control team in these countries. This is the reference used in this presentation. And thank you for being attentive to me and the time for questions. Thank you.
You can always ask people to put their hands up again as well. Thanks, Hannah, for that excellent presentation. I would like to invite the virtual panel members to join you for some questions. The panel members for this session are Muzammil Hamid, Malemba Samatella, and Kenawando. So if you would like to turn your cameras on as well, that would be great. We have a question from Peggy to start with, which is what are the ways neonatal sepsis can be prevented in a rural area?
Actually, neonatal sepsis, it's common in healthcare setting where we have poor management, and it is mainly associated with preterm delivery. And in rural area, if there is a control in the setting, I think it will.
Hi, can I add some comments on this?
Yes, please do.
Yeah, this is really a big challenge here in our rural settings, but as far as I'm concerned, there are programs for nurses, educations, and how to for the sterilizations and using the sterile tools when they are dealing with during pregnancy, especially delivery at rural settings and even at homes, at villages. So there is regular education programs, but if these cases can occur, they refer to the nearest hospital where they can take further precautions. They use antibiotics and sometimes they refer to surgery. Okay.
Another question. Great, thanks both. We have another question just come through from Ishmael. Where's it gone? The question is, how can we increase surveillance level of multi-drug resistant organisms in low and middle income countries?
Surveillance can be increasing by regular detection of and rapid identification of multi-drug resistant organism, and with good and reliable micro laboratories in these countries, and we need reliable identification of the pathogen and use is good antibiotic panel to detect this resistance. Yeah, I think.
Great, thank you.
Thank you.
Do any of the other panel members have anything to add to that?
I think just we need to go to digitalization. So we have to have a system for a surveillance system in place, so it should report these cases from the different laboratories, and then we have one at least one central unit, so they can gather all these informations and then can share it. So, but we are aiming to, we have discussed this in our workshop for PANDORA forum kickoff for arboviruses, that we need to have a working surveillance system. So, and if we go digital, if we just make it computerizations and digital ones, it would be good. One.
Great, I think that's a really good point. Thank you. Okay, on to the next question from Christiane. MRSA and ESBL are classified as alert organisms because they are multi-drug resistant. If this is the case, then why aren't some MSSA, so I should assume methicillin sensitive Staph aureus, classed as multi-drug resistance? Why aren't they alert organisms too?
Okay, this is a good question. Multi-drug resistant or MRSA, it is a multi-drug resistant organism, and it is resistant just to methicillin or beta-lactam. It's also acquired resistant to other bacteria, and the infection of multi-drug resistant is hard to control it. That is why it's alert organism.
As Hannah was saying, MRSA is known to be mild drug resistant, as well as the ESBL producing bacilli. So these are known to be resistant to more than one class of antibiotics, hence they are late. What's the major key thing to think about is that these are carrying genes which are easily transferable to other bacterial populations other than Staphylococcus or the gram-negatives themselves. Hence, they are late compared to the MSSA, which may not be carrying the genetic elements such as the pathogenic islands or even transposons, which are likely to transfer the resistant genes to other organisms. So of course, current research seems to show that we must still put an eye on the MSSAs, because in due time they acquire the resistance genes and then become a reservoir for passing on these genes to other bacteria.
Okay, so for patients who screen positive for an antimicrobial resistant organism, what is the action that should be taken? Are they isolated or treated? And that's a question from Jan.
Yeah, it is a very important question. First, the isolation of this patient, and the second step is to know either it is pathogenic or colonization. If it's pathogenic organism, yeah, the treatment therapy is very important, or just isolation in case of colonization. Yeah. Thank you.
Great, thank you. Does anyone have anything else to add? No. Okay, we'll move on to another question from Techno. So it says, like for COVID-19, most people are asymptomatic with no signs or symptoms, but prove to be positive after lab analysis. And these people can easily be spreading disease from one person to another. So what are the necessary measures to be put in place in order to curtail the spread at community level?
We should have infection and control measurements in place for every settings. So and also there should be surveillance in place to determine the impact of such pathogenic organism.
Thank you. I think it highlights a very good point, doesn't it? That lots of the surveillance systems that are in place are from patients who present to the hospital. So there's not as much data about community transmission, and arguably that seeds the problems. It's where it starts. So yeah, I think there's still a lot of work to be done in that area. I think that's a very good question from Techno. Okay, great. We shall move on to a question. I'm sorry, Hannah. Yeah.
Sorry, this is Mulemba. I need to say, maybe just to add there, we probably need to also emphasize the need to educate the community on infection prevention measures. And also, I think this has to do more with human behavior. So in the case of COVID, if one is asymptomatic and they only know that they are infected once we do a lab test, it means that we're likely to get resistance from them to put in place measures such as wearing a mask or washing hands. However, this is something we still must do to sensitize them, to let them know that they may be feeling okay, they may not have signs and symptoms, but they could potentially be carrying the pathogen. Hence, they must take the precaution, not only for their sake, but for the sake of others whom they may transmit the pathogen to. Thank you.
Thank you. Okay, where are we up to? Okay, question from, sorry, my questions keep jumping around. Question from Guy. When carrying out surveillance, should we include all bacteria or the most common? And then also for MTB or for TB, do we perform separate surveillance?
Yeah, well, I think it's important to include all the bacteria in surveillance to evaluate and to know the problem. The multi-drug resistant TB and sensitive TB strain, all strains supposed to be in the surveillance, and after that we can evaluate and to know the impact of the resistance. Thank you.
Thank you. Maybe just to add.
Great.
Could I go ahead?
Yes, please do.
All right, thank you. Yes, it would be important to include all bacteria, but then if resources are not readily available, then we could at least focus on the ones that are already known to be more of a challenge, the more drug resistant ones. but of course be on alert for any other that may emerge. As for separating the surveillance, I think again it has to do with the issue of availability of resources. There will be bacteria that may be safe to work in a certain level of a laboratory compared to others that may need more sophisticated equipment and laboratory structures. I think all those will be factors that we'll have to take into consideration when we consider what we'll do surveillance for and whether to combine or not to. Thank you.
Thank you. Masmil, did you want to add anything?
Yeah, but here because also we have to justify for making surveillance, because here we have on place we have surveillance for TB, so it is difficult to integrate others surveillance for other bacteria. So we should first prioritize what type of bacteria, what organism they need to be monitored, and then again back to the as the previous speaker said, is the resources. But for the bacteria, the gram-negative, they are very important. They are very important, especially in pregnancy and in neonates. So those need to be surveillance and monitors. But we have to do evaluation, as Hannah said, before we identify our objectives. Okay.
Great, thank you. Okay, on to the next question from Christiane, which is which people are at high risk of MRSA infection? Because for early intervention, as you said, we need to know them before we sample them.
Well, the patient for screening for MRSA, mainly in a patient in the surgical ward or in patient which have wound infection or which have recurrent infection with the MRSA. It is important to do screening to know which is endogenous infection or hospital acquired infection from the city. Thank you.
What I like, the thing is that the older the patients, the more they will be susceptible for the infections, as I mean, they are more prone to die of these kind of infections, because younger so when younger people, their immunity will be very strong. Usually they can get rid of these kind of infections. Of course, they are more susceptible to spread, but yeah, the older people are more susceptible to resistant bacterial infections, and then probably like it will lead to more morbidity and mortality. So I would say that older people should be more focused, because they are more susceptible. They are more likely to carry the resistant bacteria. Yeah.
Great, thank you. Okay, moving on to the next question from Ishmael. What strategies do you think healthcare settings in low to middle income countries will use to effectively perform surveillance of NDRO, owing to the fact that there is poor data keeping and storage of biological specimens?
I think hospital-wide incident surveillance is the most effective strategy because it's provide data and identify the cluster of the pathogenic organism in the healthcare setting. Yeah. Thank you. Yeah.
Thank you. Any of the other panel members want to add anything?
Yes, I could add something. So I think this is a very important question, because as the problem is stated out there is that of poor data keeping and storage of biological specimen. it's really a hard question to answer because governments would have to come in. Say, if you're looking at government hospitals, they'll have to come in to procure the computers and ensure that there's good internet connectivity or some form of networking within the hospital so that the data is kept well. As for biological specimens as well, we would need equipment such as freezers or indeed just space where these can be stored. So I think this has to do more with capacity building in terms by the policymakers, the powers that be, to look into this. Of course, personal attitude amongst the employers also would be good, where we begin to value the information that is generated, say, in a laboratory, and think that we must keep it safe. If it's the books, we ensure that they're kept in a safe, dry place, free from rodents and other environmental conditions that would destroy the information. So yes, we need to change our attitudes as professionals, as well as engage the governments and other stakeholders to help procure the equipment that is needed for this. Thank you.
Thank you.
In addition, we should also have in place the quality assurance and quality control procedures for those laboratories, and we try to upgrade the system they have and building more capacity in terms of equipment and human resources, and also reportings and data sharing. Yeah.
Great, thank you. Okay, moving on to the next question, which is more about the laboratory diagnostics. So when we use molecular methods for screening for AMR, how can we be confident that a gene belongs to that kind of bacteria? Because we know we can pick up DNA from many bacteria at the same time using these molecular methods.
It depends on molecular method. If you're using gene detection, PCR, or real-time PCR, in the beginning, it is supposed to make isolation and identification, microbiological identification of these isolated organisms, and after that, detection of resistant gene. Yeah. In this molecular, yeah.
Yeah. Importantly, we should have protocol SOPs, and we have procedures to prevent contamination and cross contaminations, and then we have to have controls. We have to have positive control and negative control in every assays, and also we have to compare. We have to use to inject the bioinformatics. The bioinformatics has a very important role. So you can compare your data with the data which is in the gene bank, and you make sure that bacteria is more likely to be the species you are looking for, and the resistant gene is the same. And also you trace the origins of the genes.
Can I add something?
Yes, please.
All right. Just to help Claudians, knowing that after extracting DNA and the bacteria that we have isolated is the bacteria we are looking for, we use certain things called primers, which are known to detect certain or target sites of a certain bacteria. So if we have those in our system, then we'll be able to tell that this bacteria is the one we are looking for. Apart from the level of the use of primer, we can do full genome sequencing, and then we can compare the sequences that we have found and compare with the kind of bacteria we are looking for. So we'll be able to tell using molecular screening or methods that this is the bacteria we are looking for. or this is the new bacteria we have discovered. So that will help us to identify and answer his question on how to know this DNA is coming from which type of bacteria. Thank you.
Thanks very much for that. Okay, we'll move on to a question now from Alexandra, who wants to know how do you define if an infection is nosocomial, and what can we do to significantly reduce it in urban areas?
Well, it is a very important question to know which is the nosocomial pathogen or not. Actually, nosocomial or hospital-associated infection, mainly with the patient which is admitted in the hospital more than 7 days to 10 days, more than a week. And if he gets infection in the hospital, that means it is nosocomial infection or hospital-associated infection. If not, before that time, mainly it is community-acquired infection. And another thing, when we're doing biotyping in the microbiology lab, and isolation of and repeated isolation of the same microorganism from the same word from different patients, that means it is nosocomial infection or hospital-associated infection. Thank you.
I can add something. We can also employ the metagenomic here in the wards, in the hospitals, in addition to the methods already Hannah said. So we could make sure these indeed are the hospital-acquired infections using the metagenomics approaches. Okay.
Could I also add, in the last part of the question, it says, how can we significantly reduce them in urban areas? I think this is where infection prevention control measures come in, where we must emphasize that the health workers follow these, as well as educate the patients and the caregivers in the cases where we have a caregiver by the bedside, to the family caregiver to help, because as we saw in yesterday's presentation, usually the infection moves from the patient to the one health worker, then to the rest of the environment, as well as other people in the ward. So we must emphasize that we work on our IPC measures. Thank you.
Great, thank you. Thanks very much for that. Okay, moving on to the next question from Roland, who asks, what are the main steps to setting up an effective surveillance system for MDR bacteria in the laboratory?
Which one?
Could you repeat the questions again?
Yeah, of course. The question is, what are the main steps in setting up an effective surveillance system for MDR bacteria in the laboratory?
First of all, early detection of the multi-drug resistant organism and good identification in the lab. And after that, monitoring if there is repeated isolation of the same multi-drug resistant organism. And after that, we can conduct surveillance to monitor the spread of this multi-drug resistant organism in the setting.
In addition, we would need to have a good reporting system and data sharing with different health settings, and also with good communication with the Ministry of Health and State Minister of Health, and try to bring the issue and to discuss what are important organisms, how to make a good system to surveillance and monitor such organism, and also management later on. Okay.
That's great, thank you. Okay, so this is a question from Henry directed to Hannah, and it says laboratory diagnosis is often ignored or not consulted, especially in sub-Saharan Africa. Again, equipping the laboratory in these countries is not a priority, but rather importation of third-generation medicines to areas where surveillance has not been undertaken. Do you think this can help the global effort against AMR?
Well, yeah, I think this is a important and common problem, yeah, in these countries. We need good communication between the laboratories and the other boards in the healthcare setting. We need reliable microbiology lab, and we need more improvement and improve the capacity building of micro lab in these countries, and to have good communication and to have rapid detection and rapid report to the clinician, that to improve the connection between the lab and the clinician in this country. But I think it is common in these countries and even in Sudan. Yeah.
I think also we need to emphasize on the training, so training the lab personnel, and also to have a way of quality control, internal quality control, and also external quality control, and yeah, increase the awareness and communications.
Just to add, so in yesterday's presentation, we saw that, no, actually today's presentation, sorry, Hannah, we saw that the prevalence of resistance differs from country to country. So yeah, that underscores the need for actual laboratory testing within the local settings. So it is important that countries prioritize laboratory testing of organisms other than empirical treatment without tests. So if we are going to act on empirical treatment, then we must have local data that inform the decisions made by the clinicians within the local setup. So yes, it is important that equipment as well as training of the staff be done within the local settings. Thank you.
Yeah, and also in addition, empirical treatment, when we have good microbiology and do cumulative antibiogram and cumulative antibiotic report, based on it, we can develop the empirical treatment for the pathogen and develop the treatment guideline in the setting or in the hospital. Thank you.
Thank you. Okay, moving on to a question from Jan, who asks, how can we go about screening for ampsy beta-lactamases, given that the methods are tedious and are difficult to apply in routine laboratories?
Actually, screening for carbapenem resistant in routine laboratory based on AST or antibiotic sensitivity testing. When we use more than one carbapenem, for example, ertapenem and imipenem, if it is resistant to those antibiotics, this is indication for carbapenem resistant or carbapenem producer. Another step, we can do confirmation by using this combination or screening test like CARBA-MB or carbapenem with EDTA. These methods can be used in microbiology, apart from molecular detection of resistance associated with carbapenem resistant or producer. Yeah, thank you.
And what about the ampsy beta-lactamases? Just detection of those.
Yeah, detection of ampsy. Also, we can, based on screening by cephalosporin, screening, and then we can confirmation by molecular method, or by inducible detection, between cephalosporin and carbapenem, or these organisms. That is mean the antimicrobial susceptibility testing. It's very important, because we starting the report from the sensitivity. If it is done in a proper way and using a proper antibiotic panel, it is very effective, and it's give guide or give good direction to detect the resistant phenomena, if it is beta-lactamase or ampsy or carbapenem or ESBL or other resistant. Yeah. Thank you.
Great, thank you. So we were a bit late starting the session, so we're going to just have 5 more minutes for questions, and there's a few more in the feed. The next question is moving away from surveillance of laboratory organisms to antimicrobial usage. And the question is that there are articles saying that to reduce the burden of AMR, there should be systems in place to continuously monitor physicians' prescriptions. Do Hannah, you or any of the other panel members have an opinion or thoughts on that?
I pass this question to the panel. Yeah. Anyone in the panel?
Maybe I could start. Yes, there are articles that are saying this, and I think it is a good direction to look also, because you find, like it was earlier said, that the laboratory results of sensitivity results are not considered or ignored. It means that what we're seeing in vitro is actually different from what is happening in the community. Different drugs from what could be viable are being prescribed, meaning sometimes even antibiotics that in the in vitro methods have shown to be resistant may still be prescribed out there, and that's driving the resistance in the bacteria. So I think it is a good option to consider, so that we could then compare the prescriptions as well as what we are seeing in the laboratory. Thank you.
Yeah, I think this question will be answered in the next presentation, and the presenter is Alisa Pandolfo. Is going to talk about current problems with AMR, and she's going to talk about answering questions to do with physicians' behavior in prescriptions. So keep watching. Watch this spot when slaps. Watch this spot.
Okay. In addition, I think prescription behavior of the doctor is supposed to be the doctor is supposed to stick with the antimicrobial stewardship program and antibiotic guideline in the healthcare setting, and also increase prescriptions of the antibiotic that increase the selective pressure of the antimicrobial, which is one of the resistant mechanism of the pathogen of the antibiotic, especially among resistant of ESBL.
Great, thank you for that. Okay, we're moving on to another question from Guy, and he would like to know if a country without a reference laboratory is still able to conduct resistance surveillance.
Yeah, this is good question. Yeah, I think the national laboratories is very important in countries, but in case of there is no national laboratory or we have very limited resources, maybe it work if they doing surveillance, yeah, in these countries. And I pass this question to Melimba.
Thank you, Hannah. Maybe just to add, usually the reference laboratory would be there to help in cases where the lab fails to make a decision on their findings. So if the other labs have their systems right, that is, they have control strains, which they have tested their discs and their media or whatever methods they're dealing with, then I think it is possible for them to still be able to do surveillance. Thank you.
That's great, thank you. So we've just got time for two last questions before we wrap up and move on to the next session. The first question is from Rakid. It says, I may have missed this in the presentation, but would like to know if there are any procedures in place to control infection of wounds for mothers who have delivered by cesarean section in hospitals, as this is a very common scenario.
Yeah, infection in pregnant women, mainly it is hospital-acquired infection. Yeah, and it is associated with infection with MRSA or infection with E. coli or carbapenem producer strain. Yeah, the early detection of these associated organism and control, it is very important in the control of these kinds of infection, I think. Yeah, thank you.
Thank you. And then the final question, open to anyone, is have any of your institutions created a forum which includes lab scientists, clinicians, nursing personnel, etc., to discuss the alert lab results and then to formulate the strategies to control such infection within the hospital setting?
Not yet.
This question goes. Sorry, this question should be answered by Pandora.
We have not started such forum, but it would be really important to have such to have discussed between different laboratories and health stakeholders and Ministry of Health. Yeah, but we need to have a forum for it.
Fantastic. And anyone have anything else to add before we wrap up?
Well, I don't know if I understood this question well, but I think say in my country, in Zambia, our national reference hospital does have a team usually headed by the microbiologist, which meet, I think, regularly on a weekly basis to discuss hospital infection and prevention, and such are some of the issues they discuss. So it would be good to encourage hospitals to have their own infection prevention control teams, which I think will include all these people listed here, the scientists, clinicians, and the nurses.
And just to add on top, in our institution, especially with regard to COVID-19, we have set up teams that discuss such results. So the best way that we have seen it working is to put people into smaller groups, which are dedicated to a certain kind of activity and towards the bigger goal. So every often we meet together to discuss any kind of alert that has come up. And this has actually led to a proper way of a response in case we need to respond. So it is something possible, and any institution can also make use of that kind of example. I think there is already a publication on that which you can follow up and see how we started up, made it up, and then how it works. It is possible, and we have done it. Thank you.
That's great. Thank you very much. So we're going to move on to the next session now. So I would just like to thank Hannah for her excellent presentation, and all the panel members and everyone else for a very interesting discussion and for all the questions that have come through. And I will now hand over to Ken, who is going to chair the next session.
Thank you, Kari. Thank you.
Thank you.
Thank you very much. Thank you very much, everybody. Thank you very much, Kerry, for sharing. Thank you very much, Hannah, for presentation. We are now going to the third presentation and the last one for today. And it's about stewardship, monitoring the usage. Perhaps somebody may ask, what is stewardship? In an antimicrobial stewardship, we may say that there are interventions that encourage the optimal use of microbial treatment that result in the best clinical outcome for the treatment and prevention of infection with minimal toxicity to the patient and minimal impact on subsequent resistance. And we are on this topic, we are going to have two presenters. Presenter number one is going to be Dr. Vicky N. And then presenter number two is going to be Alicia Padolfo. So I will talk briefly about Dr. Vicky N. And when Alicia will be presenting, I will also talk about her bio sketch. Dr. Vicky N is a senior research associate at the Center for Clinical Microbiology at the University College London in UK. She is also a project manager on the INHALE project, which aims to compare patient outcomes, define impact on antimicrobial stewardship, and assess clinicians' perceptions and acceptance of the chosen molecular diagnostic test and its value for money. She has a broad range of experience in various aspects of antimicrobial resistance, clinic and microbiology, and molecular microbiology. Particular topics of interest include rapid diagnostics, mobile genetic elements, fitness cost of resistance, genetic regulation, and persistence of resistance in the absence of selection. Without taking much time of Dr. Vicky, I welcome Dr. Vicky. Dr. Vicky, please welcome.
Thank you there for the kind introduction, Ken. Am I able to share my screen, or are they going to be shared by the network slides? Oh, I shall try. Okay. Share. So can you all see that?
Yeah, but can you put it in slideshow, please, Vicky?
Yeah.
That's great. Perfect.
Yeah, so this is going to be a joint presentation by myself and my colleague Alyssa Pandolfo. So I'm going to just give a very brief overview about antimicrobial stewardship and how we can monitor antimicrobial use. So I was pleased to see that the last session had some questions on this topic, as it leads in very nicely. It's all a simple concept. In practice, you just use, or in theory, you just use less antibiotics, but in practice, it's not always that easy. And there are a lot of behavioral factors that come in. So my colleague, Alyssa Pandolfo, is an expert on these, and she will then cover those after I have covered the basics. So I'm sure I don't need to convince you that antimicrobial resistance is an enormous problem, and if we do nothing about it, it's expected to only get worse. A few years ago now, the UK government commissioned an economist called Jim O'Neill to conduct a review on AMR, and in order to establish what is needed to fight the problem and how bad it's likely to get if nothing is done. And a lot of it comes down to economics. So he estimated that mortality due to AMR globally would reach 10 million by 2050 if we do not do anything, and it would outstrip all other potential causes of death, such as cancer, heart disease, diarrheal disease, and it would be the biggest cause of death. The projected economic losses as a result of AMR would also be predicted to be absolutely huge, so 100 trillion by 2050, which is a number so large I think it's not even possible for most of us to comprehend it. So I encourage you all to read this report. It's very interesting, and it's very well written, and it's freely available on this website here at the bottom of my slides, and it just discusses what the problem is now with AMR and how we can work together globally to solve it. So we all know that if we use too many antibiotics, we get more resistance, and this has been demonstrated very convincingly. Before antibiotics were introduced into clinical medicine, there was very little resistance around, and we now know that their overuse and misuse has led to AMR arising in both human and veterinary medicine and in the environment. And this graph here on the right, it's an old one now, but it shows it really nicely. It shows that countries that have low levels of beta-lactam use also have low levels of penicillin resistance in Streptococcus pneumoniae, whereas countries with high levels of use have high levels of resistance. So that's clear, but what can we do about trying to mitigate and reduce the problem? So antibiotic resistance spreads in the environment. We need to really effectively solve the issue. We need to consider all these different factors. So it's not only a case of people taking too many antimicrobials in medical settings, such as in the community or in a hospital. Once that then happens, even if they are cured, they may create antibiotic drug-resistant bacteria that develop in their gut. Those can then spread within a hospital, as we've been discussing in other sessions in this workshop. They may also spread within the community or within a household. Antibiotic resistance bacteria can pass to humans from food, so that's where from farming, so where antibiotics are used in farming, farm animals will have drug-resistant bacteria and they can pass to humans from food, but it can also occur the other way around. So humans may pass their antibiotic resistant bacteria onto their pet or livestock, and then obviously we also need to think about the environment such as the soil and water. So one of the best courses of action, apart from preventing the spread of resistance, is to reduce the volume of antibiotic use overall. But today I really will be focusing on how to do this in a healthcare setting. So what do we mean when we talk about antibiotic misuse? It can be underuse. So that's when antibiotics are not actually used enough, for example, due to lack of resources or lack of drugs. So that's when a patient that genuinely needs an antibiotic is not able to access it. And that's obviously not good for patient outcomes. Unnecessary use is when an antimicrobial is not indicated and there's no health benefit for the patient. So for example, prescribing an antimicrobial for a viral infection where it's known not to be effective. And another problem, which is probably just as great but less well appreciated, is inappropriate or suboptimal use. So that's when a patient does need an antibiotic of some kind, but the choice or administration is incorrect. So for example, a delayed administration in a critically ill patient, the wrong choice of antibiotics. So it could have too broad, most often that's when it's too broad a spectrum. So say you have something that is susceptible to a simple antibiotic like a penicillin, and you're instead giving that patient a broad spectrum antibiotic like a third generation cephalosporin or a carbapenem, and then this selects for resistance in sort of valuable last resort antibiotics. Or you may have the opposite problem where you're giving a patient an antibiotic where the spectrum isn't wide enough for the organism that's infecting them, perhaps because that is a resistant organism like an MRSA or an ESBL that has acquired resistance genes and you don't know about it. And then you wouldn't be adequately treating your patient. The other is a mismatch between the drug and the bacterium. So if you're not giving the right antibiotic for the right bacterium, so for whatever reason that bacterium is not susceptible to that organism, perhaps due to some intrinsic factors, or if you have the wrong route of administration, you're giving oral antibiotics when you should be giving IV antibiotics, or vice versa, or you don't have, or the length of the course is not correct. A lot of people think that you always have to finish the course or that a longer course is better, but actually that can select more antibiotic resistance if the infecting organism that the infection that you're trying to clear is gone. There's no benefit from prolonged antibiotic use. All you're doing is potentially creating other issues by selecting resistant organisms in the patient. So what can we do about it? Well, antimicrobial stewardship is one potential solution, and the definition of that is really the right antibiotic for the right indications, having the right diagnosis for the right patient at the right time with the right dose and route, causing the least harm to the patient and crucially future patients. So this is where it can get difficult. So you want to do the best for the patient that's in front of you and give them the best that you have available, but you also need to think about selecting resistance in your healthcare setting and taking into consideration by the fact that if you select for resistant organisms, they may then infect future patients that could be more difficult to treat. And this is where this concept it's tricky. So this just, sorry, the resolution on this figure is not fantastic, but it's Essentially, you need to choose the right antibiotic. So what organisms are infecting the patient? What are the risk factors? Can the antibiotic get to the site of infection? Do they actually have a true infection and are not just colonized? So that's the right time. Did you get cultures before initiating antibiotics, if that was possible? Was the patient given antibiotics straight away? Is the dosing appropriate for the patient and for any other issues they might have, like renal or liver issues? Is the patient a good candidate for oral treatment, or should you be giving them IV antibiotics? Is it the right spectrum of antibiotics? I already spoke a little bit about this. So can you give a narrow spectrum? You should always give a narrow spectrum if you can, and if it's safe to do so. What's the minimum duration you could choose, and what antibiotic has the least amount of side effects? Sorry. Okay, so the benefits of a good antimicrobial stewardship program. So there's three benefits here. So you improve patient care. So you're not only looking after antimicrobial resistance, you're also treating your patients better, and they will have better outcomes. We reduce what we call collateral damage. So you reduce other issues that can be associated with inappropriate antibiotic use, such as less toxic side effects from toxic antimicrobials, less potential Clostridium difficile, which can be infected, less line infections, less length of stay, and reduced use. And if you do this, you can also have a positive effect on costs. So less overall cost for your healthcare setting and savings. And these benefits sort of accumulate over time. So you can improve patient care immediately, but if you practice good stewardship in the long term, you can also reduce the so-called collateral damage and reduce your costs. So how could you start to develop an antimicrobial stewardship program in your setting? And I appreciate it can be a big thing to do, and it can be challenging. The first thing really is you should understand your current antibiotic use and resistance as best you can. You can run audits or surveys. You can look at records from your pharmacy or purchasing. You can carry out long-term surveillance of usage, but you would need quite a lot of resources for that. And you should have a laboratory supporting these activities by carrying out surveillance of antibiotic resistance pathogens, because often you can choose the antibiotic based on what your local antibiotic resistance rates are. So if you know that you never see resistance to a particular antibiotic, then you can probably safely prescribe it. Whereas if you know your resistance is really high, you should try and avoid it if you can. You need to identify the problems, such as poor patient outcomes, high levels of resistance, high expenditure on antibiotics, or high prevalence of antibiotic-associated adverse effects. And then try and identify the most appropriate stewardship measures for your setting. There's two sort of sides to this of what the key components of a successful AMS program might be. So you need to try and affect some organizational level changes. So there needs to be motivation within the team to want to do this. If nobody wants to do it, it won't happen. You need to get the leadership and the decision makers involved. It's really important to have a clear structure and process. And then it's important to run educational workshops so that people can see the benefits of this. So how can you do it? What kind of things could you do in practice? So you could restrict a particular antibiotic. You could restrict microbiology results. So if you have a bug that's susceptible to all antibiotics, you only release the results for the ones that you want the clinicians to prescribe. You can develop prescribing guidelines to help people prescribe appropriately. You can improve diagnostics, and when you couple this with stewardship, it's called diagnostic stewardship. You can have ward rounds examining people's antibiotic use, and you can, what you always need to do is, once you have introduced an intervention, you need to work out how successful it is by monitoring its success. So some further ideas of what you can do is obviously enhancing infection control and prevention goes hand in hand. So not only are you selecting less resistant organisms, but if you also have good infection control, as we have discussed, then those resistant organisms won't spread from one patient to another. You should control the source of infection. Only prescribe antibiotics when they're really needed. Make sure the dosage is right if possible. Use the shortest duration of antibiotics based on evidence. Reassess treatment when culture is available. Support surveillance of AMR and hospital-acquired infections by monitoring antibiotic consumption. Carry out education and support an interdisciplinary approach to ensure that different specialists work together and everyone appreciates the importance of doing this. And this was sort of a very, very quick overview of antimicrobial stewardship. It's a large topic. In the reference list, we've given you some resources. There's some really excellent resources available online that are free to access. Some of those are developed by the British Society of Antimicrobial Chemotherapy. There's an ebook that you can download where most of my presentation material came from, but it's expanded on it's elaborated much more than what I've been able to deliver in this time. There's also online courses you can attend. So I really encourage you to take advantage of those free resources that exist and how you can learn more about this topic. So I'll now pass on to my colleague Alyssa Pandolfo, who's going to talk about how important behaviour is in all of this.
Thanks, Vicky.
Alyssa, do you want me to move your slides, or do you want to move your own slides?
If you could do that, that'd be great.
Okay, thanks.
All right.
Just in 1 minute, Alyssa Pandolfo is a behavioral scientist at UCLA, specializing in understanding how clinicians make decisions about antibiotics. Her research examines the influence of doctors' beliefs and the prescribing environment on starting, changing, and stopping antibiotics in critical care. She's also interested in exploring doctors' attitudes towards novel prescribing technologies and their influence on the adoption. Ladies and gentlemen, let's lend our ears to Alyssa Pandolfo. Some of you have already started asking this question before she presented. Welcome.
Thanks, Ken, and thanks, Vicky, for the really good introduction to AMR and AMS. So I'm just going to build on what Vicky's already talked about. And I would like to talk to you today about behavioral influences that should be integrated into AMS programs. So next slide, please, Vicky. Thank you. So I'm going to talk to you today about two behavioral factors, which are the clinician's beliefs and the prescribing environment. I'm going to go into these in detail a lot later. And I'm going to be drawing on examples from two studies. So the first is work that Vicky and I did along with our colleagues on the INHALE project. We did 4 focus groups and 34 interviews with ICU clinicians in the UK. I'm also going to be drawing on a study by Tarrant and colleagues who did 46 interviews in the UK, South Africa, and Sri Lanka with hospital clinicians to give a more low and middle income country perspective as well. Next slide, please. So over here we have our clinician who is about to make an antimicrobial decision for their patient. Next slide, please. And the clinician has beliefs about antibiotics. More specifically, they have beliefs about the benefits of antibiotics, as well they have concerns about antibiotics, And both of these beliefs would influence their decision-making processes. And I'm going to give you a couple of examples of those. Next slide, please. So the first would be beliefs about the benefits of antibiotics. So in addition to what you would normally think about these kinds of benefits, such as preventing patient mortality, preventing patient deterioration, there are other less commonly realized beliefs that doctors had brought up in the interviews that we did. So in the first quote, this doctor is talking about how the patient has already gone on to meropenem, a broad-spectrum antibiotic. And they're talking about how the meropenem was keeping an infection at bay. So rather than curing an infection that the patient already had, it was preventing one. And the second quote, which is from a doctor in South Africa, this doctor is saying that, well, the patient can't afford to stay long in the hospital because if they're in the hospital, they can't go out, they can't earn a living, they're losing out on wages, and they also have to pay for hospital costs. So if you start off with a broad spectrum antibiotic, it gets them out of the hospital quicker, it minimizes their hospital costs, and they can go back and earning their wage. So they describe this as a win-win situation. So both of these beliefs about preventing an infection as well as making sure that patients can afford hospital costs and whatnot, those encourage an overusage of broad spectrum antibiotics, and that could lead to AMR. On the flip side of this, next slide, please. On the flip side of this, we have beliefs about the concerns about antibiotics. So these concerns could be things like adverse drug effects, they could be things like C. difficile infection, and they could be about AMR, and I'm going to focus on AMR on this slide. So the first quote is talking about how this doctor wants to have their patient to have antibiotics, despite the fact that there is this theoretical risk of resistance. So the word theoretical here implies that the doctor is doubting whether resistance is going to occur. And if they're not entirely sure whether resistance is going to occur in the future, they may be less willing and less motivated to participate in an AMS program. The second quote is from a doctor in Sri Lanka, and they're talking about how they're trying to do what is good for the patient, and that's the only agenda they have. So they're describing how their patient comes first, and during decision-making, thoughts about AMR come second. They're not as prioritized, and this is also something that we found in our interviews. So both of these things need to be taken into account, because if they're not thinking about AMR when prescribing antibiotics, or they don't believe in AMR, that's going to affect the motivation to participate in an AMS program. Next slide, please. So we have the clinician with their beliefs of antibiotics, and they are also in a prescribing environment. So what would that be? Thank you. So it would be things like patient factors. So how severe is this patient? Do they look really unwell? Are there stewardship programs in the unit that are affecting how antibiotics should be prescribed? What are local prescribing practices? For example, one of the units that the doctors I interviewed were saying that normal practice is having a minimum 5-day course of antibiotics. If you prescribe less than that, then you're going to be seen as deviating from the norm. Also, what kind of resources are available? Do you have rapid access to culture results, for example? Could you talk to specialists that could help with your decision making? What are the prescribing guidelines on your unit? Are there prescribing guidelines on the unit? Things like that. So I'm going to give 2 examples of what I mean by the prescribing context. So the first is about external team members or specialists. So the first quote is talking about a consultant microbiologist. And this clinician is saying that if you go on their ward round and you can't defend why the antibiotics, what are the antibiotics for, when is it going to stop, then the microbiologist will challenge that. And that clinician recognizes that this challenging has resulted in them shaving a few days off of their antibiotic usage. And the quote got cut off, but he continues on to say that that challenging has led them to achieve their desired target usage of antibiotics. So it reduced their usage. On the flip side of that, we have a quote talking about a particular gastrointestinal surgeon who, despite having the normal practice on the unit being 24 hours of antibiotic prophylaxis for hepatitis, they insist on doing 5 to 7 days. And this clinician is saying, try as many white, we can't get that stopped. And you can see how in the first quote, this microbiologist is improving antimicrobial stewardship by questioning potentially unnecessary antibiotics. Whereas the other quote is talking about how a different person may discourage stewardship or encourage suboptimal antibiotics. Next slide, please. Another element of the prescribing context that I think is important is about prescribing guideline adherence. So before I get into this, I want to say that adherence to prescribing guidelines is good, but it also depends on how good your prescribing guidelines are. If they're tailored to the patient population and to the types of bugs that you normally see in the unit, then fantastic. But if it's a poor set of guidelines, then adherence does not really matter because the guidelines themselves are suboptimal. But in the interviews that we did them at 4 different UK hospitals, and we noticed that between the hospitals, there were different views on how, on the rules about following guidelines. So the first quote is talking about you have to go with the hospital protocol because it's designed with their patient demographics in mind. Similarly, other clinicians in this unit were talking about getting a slap on the wrist if you deviated from guidelines. Conversely, the clinician in the second unit, which is in the quote below, is talking about how guidelines are guides rather than policies and protocols. And he says the guide in guideline means guide rather than insist. So when designing an AMS program, having an idea of whether doctors in your unit are going to follow it or not is really, really important, because you could have a fantastic program, but if they're like, well, it's optional, it may not be as effective. Next slide, please. So you have the clinician with their beliefs and in the prescribing environment, and then they make an antibiotic decision. So next slide. Yep. Yeah, they make an antibiotic decision. Next again. So what does this mean for AMS programs? So I think my first, oops. So I think my first point is that behavioral factors tend to be under-considered in AMS programs, but there's a lot of evidence that say that they really influence how antibiotic prescribing decisions are made, and they also influence how effective these programs are. So I would really urge you to consider them. So there's a really good article by Denise and colleagues, which I've included in the reference list, that maps how you can include psychosocial factors into AMS program design. So this could be an extension of what Vicky's already presented. So the first step would be to assess the specific context needs. So understand in your local environment, whether that be a ward, a hospital, what have you, is the problem behaviorally. So it could be what are people's attitudes towards antibiotic prescribing AMS programs? What are people's motivations like? What are social influences of prescribing? Does your unit have any norms about prescribing or following guidelines? So you could do this through a questionnaire, you can do this through interviews, you can do observations on ward rounds potentially, but it's important that you talk to a lot of different people, if not all the people who are involved in antimicrobial prescribing on your unit, because they will have the best idea of what is going on the ground. So once you've identified what potential barriers are to AMS, you can design an AMS program to identify these barriers. And you can do this in collaboration with key stakeholders as well. The third step is to implement the AMS program. And the authors recommend that you have a communication strategy between the multidisciplinary team members, just to make sure that everyone is on the same page and there's a constant flow of information. They also recommended doing some training programs with communication and with optimal prescribing. And the last step is to follow up. So monitor antibiotic usage and feed that back to AMS stewards, to prescribers on the unit. And that way, if there's progress, it kind of motivates people to keep going. You can also identify any problem areas and modify the intervention that way as well. And you can also look at potential issues that would cause a relapse to suboptimal prescribing in your follow-up session as well. Next slide, please. So key takeaways. So the first is that behavioral factors influence antimicrobial prescribing. So clinician beliefs and the prescribing environment are the two main things. And they should be taken into account in stewardship programs, but they're not really taken into account in many. So these factors may vary between clinicians and between hospitals. So this is really important to assess at a local level, because what works in one hospital may not work in a different one. It should be locally tailored. And yeah, locally considered when you're designing and implementing stewardship programs. And by doing this, you will be able to have a more effective program, which is more tailored and would hopefully lead to a better result. So thank you so much for listening to the presentation.
Thank you, Alyssa. I just wanted to point out the reference list here. So the two top references are the ones I spoke about, which are free online resources about and provided by the British Society of Antimicrobial Chemotherapy about in order to learn more about antimicrobial stewardship. And the other three are the behavioural studies that Alyssa mentioned.
Yeah, I would highly recommend the Denise All article, because it gives a step-by-step approach to integrating behavioural factors and psychosocial factors into your AMS intervention. So it would be a good supplement to the resources that Vicky's provided.
Okay, thank you, Dr. Vicky, and thank you, Alyssa. We have about 20 minutes for the question and answer, because we need to conclude by 12:45. So can I welcome the question? Let me see there is any. There's one here from Mahmoud Bala. Mahmoud Bala wants to know, if one detects that a patient is having AMR to a particular antibiotic, what else should be done in that case to provide alternative treatment for that patient?
So I can answer that one. So if the person's, I think the first thing to know is, normally when you make your antimicrobial choice, you would probably not know the susceptibility, what the pathogen is or what the susceptibility is, unless you have very rapid diagnostics available. Once you get that result, then obviously if the patient's has an antimicrobial resistant organism, you should choose the most narrow spectrum antibiotic that is still effective for that patient. So for example, if you had a patient with MRSA or methicillin resistant Staph aureus, then these are normally susceptible to glycopeptides, and those are narrow spectrum agents as well. So in that example, that might be a good choice.
Thank you, Dr. Vicky. I'm still looking for if there is any other question on the chat board. It looks like that's the only one at the moment. And if there is anybody who would like to ask questions directly, please raise up your hand. Raise up your hand so that you can be given an opportunity to ask the question directly. Okay, I think that's the only question that I'm seeing on the chat board.
I think I can see one here from the previous session. So there are articles saying that to reduce the burdens of emerging AMR, there should be systems of continuously monitoring the physician's prescription. And that's absolutely right. If you are going to have a successful antimicrobial stewardship program, then you need to do your best to monitor current prescribings and understand how any interventions that you apply are working. But this can be very difficult in practice everywhere in the world. A lot of places don't have electronic prescribing records, and even if you don't, it's still really difficult to pull the data together. So it requires a lot of work to pull this together. And one thing you can do is just do point prevalence surveys. So asking people what they've prescribed on particular days, for example, and trying to build a picture of what's going on.
Okay, thanks, Dr. Vicky. There is a question that was asked in the previous presentation, and I can probably, this is the right time to answer it. The question I was asking, there are articles saying that to reduce the burdens of emerging AMR, there should be systems continuously monitoring the physician's prescription. What's your view?
So I think this is the one I was just discussing. So I think monitoring is important.
Okay. There's another one saying that how can a doctor treat a patient who is resistant to all antibiotics?
Now that's very tricky. And I think, unfortunately, that's something that we do see increasingly. It is still a rare occurrence, but I appreciate that if you're in a resource poor setting, they may be resistant to all the antibiotics that you have available. And often the most difficult cases to treat are gram-negative infections producing carbapenemases, which would then often have resistance to all other antibiotics, like other beta-lactams, and have resistance to other antibiotics. And then normally your only choice left would be colistin, but that can be difficult to get hold of. It's not as effective and it can be toxic. So I think in those circumstances, I think you just need to do the best you can for the patient and support them in other ways with other good clinical management. Look at the MICs and try and possibly prescribe something where the bug is slightly less resistant, but it is very challenging.
Yeah, there's two more questions for you, Dr. Vicky, and this is coming from James Deke. James Deke would like to know, how can antimicrobial stewardship be implemented?
So this is a very big question to answer. So really, I think you need to understand what your situation is locally and what your problems might be, what your current usage might be, and where you can make a difference. And this doesn't need to be expensive, but as Alyssa pointed out, sometimes you have real challenges trying to change people's behavior and beliefs, because I think we're all conditioned to believe that antibiotics are good. And there's that challenge about when you have a patient in front of you and you know they need the antibiotic, you want to do the best that you can for that person. So, but really the interventions can be quite simple. So, restricting a particular antibiotic is a good place to start if you have problems with that. Making sure infection control is good. So if you do get a multi-drug resistant organism appearing in your setting, it doesn't then spread to all the other patients, writing guidelines so that when an expert is not available, non-expert clinicians can still have support, and then monitoring how those interventions are working. I don't know, Alyssa, if you wanted to add anything to that.
I just wanted to say that it kind of seems daunting sometimes, because you're like, oh wow, big stewardship program. But just as Vicky said, you can break it down into more actionable things, like designing good prescribing guidelines, making sure that doctors are aware of the issue of AMR, making sure that they are aware of the downsides of having antibiotics overly prescribed, things like that. So you don't have to make it a one big thing. You can break it down into more actionable steps.
Yeah, and there's some really, really good, like I said several times, free online resources to help with the education. So you could start by just, you know, familiarizing yourself with those resources, and then organizing local sessions to share those resources among your colleagues.
Yeah. Thank you, Vicky. There is one from Ishmael Conte. Ishmael Conte is complimenting Dr. Vicky and Alicia for the wonderful presentation. But his question is, how can one increase behavior and attitude of healthcare workers towards AMR stewardship?
Yeah, I can answer that. So it basically depends on what the current attitudes are. So for example, a lot of the doctors that I was interviewing were like, well, I really want to take AMR into account, but my top priority is a patient. AMR comes second. And it also kind of comes to my patient is my responsibility. AMR is not. So trying to make AMR, rather than a collective responsibility, making it more individual, that would help. So yeah, it would really depend on what your attitudes are in the first instance.
Thank you, Alicia. And there's still one more. This is coming from Wenceslas Landemba. He is asking, is it serious for clinicians to prescribe antibiotics for more than 10 days when we know that most of them are not really relying on the lab to do so?
So I'll try and answer that one. So I think shortening the duration of antibiotic courses, obviously for organisms other than TB, is a good thing if you can be confident that the infection has cleared. So either if you have laboratory evidence that the pathogen is no longer there, or if there's clinical evidence that the patient's infection has resolved, then I think it's good practice to stop antimicrobial prescriptions earlier in order to reduce the risk of them selecting further resistant organisms, either in the patient's gut, for example, that could then make that patient ill again, or could be transmitted to other patients.
Thank you, Dr. Vicky. We still have 4 minutes more, and there's one more question before we hand over to Max. And the question is, how can we, the idea of AMR to differentiate between symptomatic and asymptomatic patients? I'm not so sure that this makes sense to you, Vicky. How can we, the idea of AMR?
You know, this makes sense to me. So I think this is, how can we differentiate between symptomatic and asymptomatic? So I think, if I'm understood it correctly, is how can we differentiate between infection and colonization? Is this the question? Because sometimes we can find bacteria in a patient, but they are not actually making the person sick. So I don't know if this is what we mean, or is that, or do we mean that can we find out from the patient's symptoms if they have an AMR resistant organism or not? So I'll just try and answer both of them. So the first one is, it can be really challenging to differentiate when a patient is infected versus colonized. So some blood sites, body sites, it's easier. You know, if you have an organism in the CSF or in blood, then you know for a fact that it shouldn't be there. and you need to treat that infection. But if you have something in the lungs, for example, which is my, my specialism, I need respiratory tract infections, you don't always know if it's actually causing the problem, or in the gut somewhere like that. It's difficult to tell. So the best tool that we have is trying to do quantitative culture, but that can be challenging. And obviously clinical judgment and management. Does the patient appear to be sick? Does it make sense for this to be the cause of the problem? Does it all add together? Answering the second question is, unfortunately, there's often no way to tell from the patient's symptoms whether their infection is antimicrobial resistant or not. You just have to do the diagnostic, either a rapid test or traditional culture and susceptibility testing. But you can know a lot by knowing your local situation. If you carry out surveillance and you know what kind of resistant organisms are present in your hospital or in your clinic or your community normally, then you have a good chance of encountering those again. And also you will pick up problems sooner if you do have a multi-drug resistant bug then introduced to your setting. You can probably find it sooner if you carry out regular surveillance.
Thank you, Dr. Vicky. There is one burning question before one burning one, and it says, a lot of countries have restrictive access to certain drugs, so that often there is only one option in many situations. How do you work with this?
That is really challenging. If there's only one option, I guess what you then need to work out is your patient going to benefit from that option, and do they really need it? So do they have an infection? What is causing the infection? And is that option that you have available going to help? So if I go back to my example of the Staph aureus, we know that all Staph aureus are resistant to penicillin because they have a beta-lactamase within their chromosome. So say if you know that your patient has Staph aureus, you've found that out in the lab, and the only antibiotic you have is penicillin, there's no point in giving it to that patient because it's not going to help. All it's going to do is going to make your resistance problems worse. So I think you just need to remember to not be tempted to give something because that's what you have. Try and work out what the patient has and are they going to benefit. If they're going to benefit, then yes, of course, prescribe them that drug. If they're not going to benefit, then all you're going to do is you're going to create more resistance by giving it.
Thank you very much, Dr. Vicky and Dr. Alicia. Unfortunately, we'll have to stop here. There are more questions still coming. I can see a question from Christian. We are going to post some of these questions, and from Wenslers, we are going to post the answers to the hub, Pandora hub, and please keep checking the Pandora hub for the answers or the response to these questions. Because of the time, we only have 4 minutes to wrap up, and I want to thank Dr. Vicky and Alicia for the great presentation. And for this, I would like to stop here and hand over to Dr. Max. Dr. Max, please.
Thank you very much.
Thank you.
Very much.
Thank you very much, Ken. Thanks a lot. Thank you so much, Vicky and Alyssa. Good to see you. I normally share an office with these guys, and obviously we're not getting to see each other these days. So it's great to see you, albeit virtually, and thanks a lot. And I'd really like to say thanks to all of our fantastic presenters. We've had a wonderful program, I think, over the last 2 days. I've learned a lot. I'm sure everyone's learned a lot. I'd really like to then say thank you. So first of all, yesterday we started off with our introduction to IPC and AMR. So we had there Chiara and Srivinas We then had our IPC measures in the ward. Do you remember the wonderful presentation from Lizzie Sitole from Zimbabwe? And thankfully, the network held up despite the heavy rains in Zim at the moment. So that was wonderful. And then we followed on today with the hospital hygiene presentation from Michael, fantastic there. Surveillance from Hannah, and then finally the stewardship session. We've just had the lovely session there from Vicky and Alyssa. So thank you so much to all our presenters. We know everybody's very busy. We really appreciate you putting together such wonderful presentations. And thank you too for the great discussions. Thank you for wonderful chairing from Ken. Ken, you've really done an awful lot. Thank you so much. Ken, who's from Global Health Network. And also, of course, thank you today to our other chairs, to Isabel, to Kerry, and of course, John Tembo for chairing yesterday. And also to our panel members. So to Malemba, thank you so much, Malemba, Muzamil, and Ken and others. So it's been really great. As Ken was saying, all of these presentations will be going on to our Pandora Knowledge Sharing Hub in the fullness of time. And we'd really encourage you to look at the Pandora Hub. And don't just look at the Pandora Hub, really look at the Global Health Network. There's such a wealth of information there. There's other groups that have knowledge sharing hubs, and I can see some of my old colleagues from the site in Zimbabwe are online today, and I think they're from the PEDICAP group, and PEDICAP's one of the PENTA studies, and that's looking to optimize antibiotic treatment for young children who are hospitalized with severe community-acquired pneumonia. So there's lots of different knowledge hubs there that you can look at. And Vicky was mentioning earlier on, and Alyssa, about online resources. And so there's lots of links there to online resources. We, for example, will also put up things about future learn sessions that we can do that are relevant to what we've been talking about over the last couple of days. So there's a great world out there that we can explore. And so I think it's great now we've been introduced to each other. So using the hub as well, we can have discussion for we're separated by many miles, but the wonderful thing about the internet, etc., and these forums is that we can actually communicate with each other, and we can share information, we can share ideas. So let's try and make sure that we do that. Keep your eyes open for future workshops from Pandora, from Alert, from the other networks, from Cantam, from Tessa, from PEDICAP. I'd also like to thank, just before we go, the Global Health Network have worked extremely hard to put this together. I think it's a great forum. Thank you particularly to Heather for all the technical know-how and making it run so smoothly, to Heather, and also to Helena and Bonnie, who've been working with us. It takes a lot of work to put this together. It looks very slick on the day, but thank you so much. And just a final thank you, as with our last workshop, I'd like to say a big thank you to Lindsay Elton, my colleague here on Pandora and Cantam here at UCL. Lindsay's put in an enormous amount of work thinking up this programme, putting it together, putting all the speakers together. So a big thank you to Lindsay. I hope I haven't missed anybody out, and apologies if I have. But thank you so much, everybody. Please look out. We'll be sending you an email, a follow-up email for the evaluation. Please make sure you fill out the evaluation, because that will help us with our future workshops, and it also means that you will be able to get your certificate of attendance. So that's important for us to get that as well. I think I also mentioned yesterday that in that email, we will be offering you the opportunity to keep in touch with us in Pandora. And then we can give you the links to our AMR resistance surveys if that's something you're interested in, if that's something that you're interested in passing on to colleagues. So someone's put in the chat, how can someone join PANDORA? So you can easily join the Global Health Network. If you just go on, just put in TGHN into your browser, or I'm sure that Helena or Heather will put it up. There you go. You can sign up to it here. They've beaten me to it. So I really recommend to you that you do sign up to the Global Health Network. It's free, and there's such a wealth of information there. So I think that's it for today. Thanks ever so much. You can see there's other workshops that are coming up that you can see on Global Health Network and that are advertised in the chat. So thanks a lot to everybody, and we look forward to seeing you for the next workshop very soon. Have a great rest of the day. Thanks, everyone. Bye now.
Bye.
Bye. Bye.
Bye.
Bye.